Good afternoon, everyone. It is a great pleasure for me to welcome our patron, Dr. V. Bhattacharya sir, for the session, and our overseas faculty and Zoom platform sponsor for the Plastiquest, Dr. B. Venkatratnam sir, and today's esteemed panelists. They are very experienced teachers, stalwarts in the field of oncoplastic surgery and microsurgery. Dr. Gautam Biswas sir is an expert and a senior teacher and doing the complex reconstructive surgeries in oncology with ease and always accepted to participate in our Plastiquest program. Whenever we invited, he participated many times in our program earlier also. I welcome you, sir.
Thank you.
Dr. Manikumari madam, she is my mentor in microvascular surgery. We work together at Usmania Medical College. She was always supportive and extended her helping hand and encouraged me to do various major surgeries along with her. I welcome you, madam. I think she might have not joined.
No, ma'am. Ma'am joined, but she's mute. I think she's
Okay.
on.
Dr. Amresh Balyar Singh sir, he is a great teacher and always extended his helping hand to all. I could do the ear cartilage workshop with his guidance and support at Usmania Medical College in midterm CME. Thank you, sir, and welcome you. And Dr. Vinay Jacob, I came to know about him when I met him in JJ Hospital when I had been as an MCI inspector for enhancement of PG seats. We had a very good time there, and very thanks for him for his nice hospitality there. I welcome you, and I welcome all other Plastiquest faculty across the country and PGs. And last but not least, our judges team who are patiently observing the program and giving marks to the PG team. Actually, this is a unique program. The competitive session in case presentations being organized for the last few weeks for 16 teams. It is a Plastiquest prelims online. So it's a competitive session. 16 teams are appearing and 2 teams will be selected from this online program and they will be appearing for finals in Apsicon 24 at Coimbatore. Everybody knew our panelist, but as a formal introduction, I request our co-organizer, Dr. Rohit, to introduce each panelist to our PGs. Rohit.
Thank you so much, ma'am. I take privilege to introduce our esteemed panelists. First and foremost, I would like to welcome Dr. Gautam Biswas sir, who is usually called as Maxilla Man of India, and is working as a consultant in Tata Medical Center, Kolkata. Formerly, sir is a professor and at PJ Chandigarh and past president of Indian Society of Reconstructive Microsurgery and formerly EC member of APSI and past president of Association of Plastic Surgeons West Bengal. Sir has been fellow in Changun Memorial Hospital, Taiwan and Ohori Hospital, Japan, and he delivered multiple orations and lectures. One is at Korean Society Microsurgery annual meeting in 2014 and Murari Mukherjee's sir's oration in Apsicon 2014 and Amit Ganguly sir's oration Apsicon 2010, and R.R. Chowdhury Endowment Lecture in September 2017. We welcome you, sir. Thank you for accepting our request.
Thank you.
Next, moving to the next panelist, I would like to introduce our second panelist, Dr. B. Manikumari Madam. She is a professor and HOD of plastic and reconstructive surgery at ESIC Medical College, Sanat Nagar, Hyderabad. Ma'am has 30 years of teaching experience in both AP and Telangana state government offices and also at ESI Medical College. She is the sole person who established microsurgery and started onco reconstruction in MNJ Cancer Hospital, Hyderabad. And she also the pioneer, she started the Department of Plastic and Reconstructive Surgery and MCH teaching program with 3 PGs at ESI Medical College. And this is the first institute to take MCH postgraduate student among the total ESI corporation. She has been the visiting professor to Department of Reconstructive and Microsurgery at Changung Memorial, Taiwan in 2010. And she conducted several cadaveric dissection courses and soft embalming cadavers with the support of the anatomy department at ESI Medical College. And she yearly conducts microsurgical skill courses where she uses very cost-effective chicken legs for the residents to practice the microsurgical skills. Till now, she has trained more than 100 young plastic surgery trainees, and her main areas of interest are onco reconstruction and hand surgery. We welcome you, ma'am. Thank you for accepting our request.
Thank you, Rohit.
Thank you, ma'am. Now we move to the third panelist, Dr. Amresh Baliar Singh, sir. Sir is a consultant plastic surgeon at Bombay Hospital and Breach Candy and Hinduja Hospital. Sir has been former professor and head of the department at Topiwala National Medical College, BYL Nair Charitable Hospital, Mumbai. And Sir been a former chairman, Board of Studies and Super Specialty Surgeries at Maharashtra University of Health Sciences. He has been former member and faculty of medicine, Maharashtra University of Health Sciences, and former president of Indian Society of Reconstructive Microsurgery and former president of APSI. Sir's main area of interest are hand and microsurgery, and Sir has done commendable work in mandible reconstruction and head and neck reconstruction, lower limb and breast reconstruction. We welcome you, sir. I think Sir is in surgery. I think he will join in 15 to 20 minutes. Now moving to our last but not the least, the young and dynamic Dr. Vinay Jacob, sir. Sir is currently honorary assistant professor of plastic surgery at Grant Medical College and Sir JJ Group and GT Hospitals. Sir is senior attending plastic and aesthetic reconstructive microsurgeon at Bombay Hospital, Breach Candy Hospital, Leelavati and Jaslok Hospitals. Sir, to his name, has many fellowships, international fellowships, out of which are microsurgery and tissue engineering fellowship from University of Modena in Italy, and breast and hand plastic surgery from Royal College of Surgeons of England, and aesthetic surgery from Barcelona in Spain, Frankfurt in Germany, Milan in Italy, and Helsinki in Greece.
Recording in progress.
Sir's special area of interest are doing all difficult and challenging reconstructions and major aesthetic plastic surgery. And Sir, area of interest is like application of regenerative medicine in plastic surgery and composite tissue allotransplantation of face. We welcome you, sir. Thank you for accepting our request.
Thank you.
Today, the PGs who are going to present the case are like Dr. Sonika and Dr. Darshan. And I would like Lakshmi ma'am to just debrief the session of today's session. Ma'am?
Yeah. I'm audible now.
You're audible, ma'am.
The PG's team from RML Medical College, Delhi is going to present the cases today. We'll start with the case presentation. This case is taken from their institute, so it will be discussed in detail. They will present in 10 minutes, and the panelists will four panelists together or differently for 40 minutes. So after that, the other teams will ask questions to the presenting team. So each team will be given 2 minutes time to ask a question. So 15 teams will be asking question to the presenting team. And later on, the spotter, instrument, X-ray, OSCE, and operative session and documentation, all these sessions are spot given. So the PG student doesn't know anything about this. And each session will be discussed for 10 minutes. I welcome the PG team. All the best to you.
Thank you.
Thank you.
And before moving, can I take a roll call, please? If you allow.
Please.
Team 1,
Team 2.
Team 1. Hello. Team 1 from Madras Medical College. PGs from Madras Medical College. Hello. Okay. Team 2 from Jipmer Pondicherry.
Present, sir. Jipper Pondicherry present, sir.
Okay.
Bharat.
Bharat. Team 3 from KGMC Lucknow.
Present. Present, sir.
Okay. Team 4 from Stanley Medical College.
Present, sir.
Team 5 from AIMS New Delhi.
Present, sir.
Team 6 from Bangalore Medical College.
Present, sir.
Team 7 CMC Vellore. Team 7, please. Okay. Team 8 from Saftajan.
Present, sir.
Okay. Team 10 from Gandhi Medical College.
Present, sir.
Team 11 Kilpauk Medical College.
Their expressions. I would see the concept of expressions.
Oh.
You don't mind.
Team 11. Hello. Team 11 from Kilpauk Medical College. Okay. Students from Kilpauk. Okay. Team 12 from MAMC New Delhi.
Team MAMC present, sir.
Okay. Team 13 NIMS Hyderabad.
Present, sir.
Vishal. Okay. Team 14 Ganga Hospital Coimbatore. Team 14. PGs from Team 14.
Present.
Ganga. Yes. Team 15. Team 14.
Sir, present, sir.
Okay, Romy, fine.
Yes, sir. Ruben.
Team 15 AIMS Bhubaneswar.
Yes, present, sir.
Team 16 AIMS Rishikesh. PGs from AIMS Rishikesh. Okay, once again I repeat. Team 1.
Present, sir. Madras Medical College.
Okay, fine. And Team 7. Team 7 from CMC Vellore.
Note it down, Rohit.
Okay, madam. Next, Team 11 Kilpauk Medical College. Okay, 2 teams are absent now, right now. Okay, fine.
2 teams.
I will stop sharing my screen.
Rishikesh,
Rishikesh.
AIMS Rishikesh.
They are
AIMS
also absent. Rishikesh is also absent. 3 teams are absent.
7, 11, and 16. Yes,
7, 11, 12, 16.
7, 11, and 16.
16 are absent.
Rohit, has the team order has been changed in the second 8, or is it the same as it
No.
has been said
Sir,
earlier?
The
Same order, sir, but
did not change, sir. Actually, 3 teams withdrawn from competition and new teams joined. So we placed them in their position. So we will circulate the table again with the team and the college name.
Okay, okay.
Gandhi Medical College and Ganga Coimbatore and NIMS joined in place of the teams who withdrawn themselves.
Okay.
Okay, sir.
Shall we start, ma'am?
Yeah, please.
Okay, ma'am.
The time will be noted by Rohit and he will announce 2 minutes before completion of time.
Okay, ma'am.
Yeah.
Uh,
You can share your PPT and start.
Is it visible?
Yes,
Oh, no, yeah.
yes, yes.
Good evening, panelists. I'm Dr. Darshan from APVMS and RML Hospital, New Delhi. Second year, so I'm CH resident from RML.
Myself, Sonika, second year resident.
And today we'll be presenting a case of buccal CA, oral malignancy, and starting with the history, chief complaints. A 34-year-old male patient, a daily wage worker by occupation, hailing from Delhi, came with the chief complaints of a non-healing ulcer over the right cheek since 6 months. History of presenting illness. Patient was apparently all right 6 months ago when he noticed a non-healing ulcer over the right cheek, which was initially of size 1 centimeter and then progressed rapidly to its current size. Patient developed the external ulcer 3 months after the onset of the intraoral ulcer. He also gives a complaint of pain associated with the lesion, which is pricking and sharp in type, which aggravates on touch and upon eating. Patient visited a local hospital where initially a biopsy was done and a diagnosis of malignancy was arrived at, and then referred to RMLH for further management. History of decreased mouth opening was noted since 3 months, making it difficult for him to consume a regular solid diet. There is also history of drooling of saliva from the right side of the mouth. He gives history of foul smell from the mouth, and there is history of change in speech present. There is no history of difficulty in chewing or swallowing. No history of trauma due to sharp tooth or any dental prosthesis. No history of any prior lesion or red or white patches in the mouth. No history of any loose tooth or loss of teeth. No history of any swellings in the neck or elsewhere in the body noted by the patient. No history of cough, chest pain, hemoptysis, pain abdomen, or any bony pain. No history of significant weight loss present. Past history is not a known case of any major medical or surgical comorbidities, including diabetes, hypertension, asthma, seizure disorders, or ischemic heart disease. Personal history. My history of tobacco chewing since 6 years is present, which was discontinued since last 3 months. The patient used to chew a combination of tobaccos, lake lime, and betel nut, which he would chew and spit out after 15 to 20 minutes, around 15 to 20 times a day. There is no history of smoking. He does give history of occasional alcohol intake, and there is no history of any diagnosed sexually transmitted diseases. In family history, there is no history of any oral malignancy or similar lesions in the family members.
Coming to the general examination, patient is a young male, moderately built and moderately nourished, conscious, cooperative, well-oriented to time-placed person. His height is 162 centimeters and weight is 58 kgs. BMI coming up to 22.1. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. The ECOG scale is 2. Vitals of the patient: pulse is 70 beats per minute, BP 120 by 80 millimeters of mercury in the right brachial artery measured in supine position. Respiratory rate is 16 cycles per minute, and the patient is afebrile at the time of examination. Systemic examination is essentially normal. This CVS, RS per abdomen, the CNS as well as the musculoskeletal system examination is normal. Coming to the local examination, on inspection, there is diffuse swelling of the right side of the cheek. An ulcer is noted on the lower aspect of the right cheek, measuring 3 cross 3 centimeters, and the lesion is 4 centimeters from the midline and 2 centimeters above the lower border of the mandible. The ulcer has irregular margins, punched out edges, and the base is covered with slough. Seropurulent discharge is noted from the ulcer. Surrounding skin has erythema and edema. Excessive salivation and drooling of saliva noted from the corner of the mouth on the right side. Mouth opening is reduced to 2 fingers and is painful. Halitosis noted. Tobacco staining of teeth is noted, and multiple dental caries are present. There's no loss of tooth or any loose teeth. Occlusion is normal. Dental formula is 2123 by 2123 on both sides. Intraorally, the lesion measures 8 cross 7 centimeters, where the extension is Anteriorly, it is 0.5 centimeters from the right oral commissure, and posteriorly, it's 1 centimeter anterior to the retromolar trigone. Medially, it is up to the buccal gingiva of the mandible, and superior margin is 1.5 centimeters below the superior gingivo-buccal sulcus. The inferior gingivo-buccal sulcus is involved. There's no restriction to movement of the tongue. No other lesions, leuco or erythroplakic patches noted in the oral cavity. No other swellings in the oral cavity or in the neck. On palpation, the lesion is tender and painful to touch, bleeds easily on touch, and no localized increase in temperature is noted. Inspector findings are confirmed. 5 millimeter enduration is noted all around the ulcer, and the skin over the cheek is not pinchable. Bidigital palpation of the mandible is normal. No thickening or irregularities noted. Examination of the neck. Single palpable lymph node of size 2 cross 2 centimeters is palpable in level 1B, and a single palpable lymph node of size 2.2 centimeters noted in level 2. Examination of possible flap donor sites. Bilateral lower limbs are normal, no scars or deformities. Bilateral lower limb ATA, PTA, and dorsalis pedis pulsations are felt. Anterior chest is normal, no deformities, scars, or any sinuses.
Summarizing, a 34-year-old male patient with complaint of non-healing ulcer over the right cheek since 6 months, with history of development of another external ulcer 3 months following the intraoral ulcer, history of reduced and painful mouth opening present. Intraoral lesion measuring 8 cross 7 centimeters with anterior extent 0.5 centimeters from the right oral commissure, a posterior extent 1 centimeter anterior to the RMT, and inferior gingival buccal sulcus is noted to be involved, and the superior extent is 1.5 centimeters from the superior gingival buccal sulcus. An external ulcer of size 3 cross 3 centimeters over the right lower cheek with impending orocutaneous fistula noted. Palpable lymph nodes noted in levels 1B and 2.
So our diagnosis is well-differentiated squamous cell carcinoma of the right cheek with impending orocutaneous fistula with TNM staging of T4A, N2B, M0. Shall we proceed with our plan of care also?
I think we should ask a few questions.
Yes, sir. Yes, sir.
Yeah.
Yes,
Yes,
sir. Done.
Before,
Yes.
based on the history, etc.
Yes.
Yes, sir.
So otherwise it will become too prolonged. Anyway, you did mention that there was no redness or white patches in the oral cavity.
Yes, sir.
What is the relevance of that?
Sir, leukoplakia or erythroplakia are known as noted pre-malignant lesions in the oral cavity, which are associated with the development of oral malignancies, full-blown oral malignancies.
Absolutely.
The precancerous lesions.
Pre-malignant lesions.
That's good. So which is considered more in favor of, so leukoplakia can be classified? You know, what is leukoplakia?
An undefined white patch noted in the oral cavity, not otherwise
Attributed to
attributed
any
other
cause.
Not attributed to any other cause. Why is that added? Do you know why that last thing has been added? Not attributed to any cause?
There are multifarious other lesions which may be confused with the leukoplakia, which may not have an associated malignant potential, such as
Your definition, why has that part been added, that not attributed to any cause? Because you can have leukoplakia due to other causes, and
Other
earlier
causes.
nomenclature used to have those added to that, which has now been excluded. This is the WHO definition, right? Yeah. Okay, carry on. So the other point is,
Can I ask one question?
yeah.
Yeah, you said there is restriction of mouth opening, right?
Yes.
How much is the restriction? Because it's, I think in the picture it shows he's able to do it fully. Can we just go back to that slide? Yeah.
Only we could admit only the patient could admit 2 fingers, ma'am.
Two of his own fingers.
Yes.
Okay.
Not open
Have you measured the inter-incisor distance?
Yes, I
Yeah.
think that is important. You all should not use as a finger as a guide. It should be measured. So what is the inter-incisor distance?
We did not measure in
Yeah.
this patient.
Okay, okay, because this is clinical examination, right? So it's your, okay, fine.
Is there any submucous fibrosis? Did you mention in your examination?
Yeah, we just mentioned regarding the leukoplekic or erythroplakic plaques, ma'am. Did not mention
Mention
about
per se.
submucous fibrosis separately, but there is no
Clinical.
submucous fibrosis
Because
lesion.
there is a restriction of mouth opening. So is it relevant?
Yes, ma'am.
Yes.
Okay.
Mentioned.
Okay, if there is no submucous fibrosis, what should, okay, let us take it that patient doesn't have a submucous fibrosis, but still he has a restriction, but it looks like inter-incisional distance is almost 4 centimeters for me, but okay, let us take it granted that he has trismus. So what should be the reason for the trismus?
Ma'am, it could be possibly due to the involvement of the masseter muscle, the muscles of mastication. The malignant
Due to infiltration.
malignant infiltration of the muscles of mastication, or due to secondary to the pain due to the involvement of said muscles.
Posteriorly, until which level it's extending? What is the extent of the posterior involvement?
1 centimeter anterior to the retromolar trigon on examination.
Okay, and on palpation, how much is that? Did you mention the induration? Extent of
Yes,
induration?
5 millimeters all around.
Okay, so as per your examination, the retromolar trigon is not involved, right? Because it's 1 centimeter anterior to the retromolar trigon, and the induration is only 3 millimeters, 4 millimeters.
Around 5 millimeters around.
Okay, so in that case, retromolar trigon is free here.
Clinically, yes.
Clinically, yes.
Okay, so if the retromolar trigon is not involved, what are the muscles of mastication do you expect to be involved?
Ma'am, you can have the.
What are the elevators of the mandible? My asking.
Temporalis muscle, the masseter muscle, and the medial pterygoid.
Where does it insert, the medial pterygoid?
Sorry, ma'am.
Where is medial pterygoid and masseter? Do you expect that masseter is involved here in this patient?
The sound is gone.
Not audible.
Madam,
Sound is not
your
audible.
sound is not.
Masseter, medial pterygoid, and what else you said?
Temporalis, the tendon part.
Temporalis. So do you expect all these 3 muscles are involved in this patient based on your clinical presentation, clinical appearance?
No, ma'am, not all 3,
Not all
but
3.
possibly masseter.
Masseter might have been in.
Okay.
Masseter can be involved, but we have not clinically been able to say that.
Yeah. That's why, because there should be some reason for your trismus, right?
Yes.
What is the retromolar trigon?
Sir, it is an area. It's an inverted triangular area at the posterior to the 3rd molar, which is formed by the apex is formed by the posterior aspect of the 3rd molar and the lingual and the buccal crests of the mandibles.
Okay, so what is in relation to the medial aspect of the angle of the mandible? The inner surface of the angle of the mandible.
So it is present on the medial aspect.
No, that is okay. That is not on the medial aspect. Retromolar trigon is retromolar trigon, as you said. I'm saying what is attached to the medial aspect of the angle of the mandible. Medial surface of the angle of the mandible.
The medial pterygoid.
So medial pterygoid. Okay.
Can I ask you, sir?
Yes.
So can I ask a question, sir?
Yeah.
I find the history to be, because you're postdoctoral people, you're senior MCH registrars, I find your history to be hugely biased towards malignancy. Suppose you did not have the biopsy report, I would have expected you to rule out other conditions as well in your history and examination. Or it could have been an infective focus with the amount of mucor, for example, you see so much. Would you have wanted to examine other histories as well? I find your history very biased, which is not what I expect from your senior level. So you should examine all the possible other etiologies also and rule them out in your history. What else would you want to ask in your history? Any other specific information would you like to get?
So history of any infection.
You should
history
try
of
and elicit
fever, history- Yes, sir.
So what he is saying is give a DD and eliminate those DDs. Right?
Yes, sir.
Yes.
Sir,
Hello?
yes, sir. So the lesion, sir, the ulcer, it could be because of an infective cause, sir, like there could be infectious conditions such as syphilis, which is not very commonly seen nowadays, but it and also some certain sexually transmitted disease can present with ulcers, or it could be non-infective, painful ulcer. It could be like an aphthous ulcer, but looking at the depth and the extension, it's not likely, but aphthous ulcer could be there. And
It could be secondary to trauma, chronic trauma, but we have ruled it out by asking for history of any
And-
dental malposition, dental prosthesis, or sharp, jagged teeth.
So your
Okay.
history should contain the history of examination of the history of presenting complaints, history of the ODP of the presenting complaints. Then you should rule out etiology. That should be the next part of your history, where you assess the etiology of the history very specifically. After that, you should assess the complications that could have happened, local, regional, and systemic. For example, for a local complication, you should have specifically asked for extent of referred pain in this case to see whether the nerve intraalveolar is involved in this case, and you have a referred pain radiating to the ear and other joints and other areas. Okay, then after that, you have to evaluate all the other parts, the general nutrition and the socioeconomic support system of the patient, which you should follow in a very systematic manner, which will help you organize your thoughts, and you won't be all over the place. And lastly, for example, your reconstruction, you have evaluated in your history with asking other sites, but obviously you would want to do a challenging reconstruction. So you should ask the endurance and the cardiac challenge status of the patient, whether he can climb up 3-4 flights of stairs and all. All this should become a part of your history when you're doing difficult and planning for difficult reconstruction. Like it's obvious in your examination when you've mentioned subsequently.
Yes, sir. We have mentioned
So-
log score of the patient as a marker for his suitability for surgery.
yes, sir.
Okay.
Okay. I think let's move on. We move now. You to ask anything else, so we can move on. Otherwise, it will carry on.
Yeah.
On examination, I would want to know whether they have marked out the.
That's later on. The plan, no?
Later on. Okay.
Plan is later on. We are coming to that,
Fair
I
enough.
think. Yeah. Right?
Yes, sir.
Now you are coming to your management, right?
Yes, sir. Plan of care.
Yeah. Okay.
Our plan of care would be to confirm the diagnosis, but in this case, we already have a biopsy proven diagnosis of well differentiated squamous cell carcinoma. Next, we would like to get a CT head and neck to stage the disease. Then chest X-ray and ultrasound abdomen to rule out systemic metastasis, and patient counseling regarding the diagnosis and further prognosis of the condition, optimizing the patient and obtaining pre-anesthetic evaluation, building the nutrition, and maintaining oral hygiene.
So can we interrupt? 1 second, 1 second. Can we go back? Yeah. So you talked about X-ray abdomen and ultrasound you do for metastasis.
As in, it is like a preliminary evaluation, sir.
See, X-ray abdomen.
No, so X-ray chest and
well,
ultrasound abdomen to rule out the metastasis.
How effective is X-ray chest in diagnosis?
Yes, sir. It's
Metastatic lesion. It's a poor choice
yes.
using X-rays. So what would you prefer to do?
An HRCT chest.
Yes. So X-ray chest is no more done for metastasis. Number one. Number two is that you've talked about, actually you'll discuss the CCT later on.
Yes, sir. The
Anything
patient has
specific when you advise CCT of the head and neck, anything specific you want? Do you you tell the radiologist? Let's say the radiologist is not well versed with what you exactly want to know. Anything specific?
We would want to look for the bony involvements. We would ask them to.
That's fine. That's fine. Any specific way to do a CCCT for
Specifically, CT scans is asking.
Sir, is it I mean, asking the patient to do puffed cheeks during the
Yeah.
PT
You
and
should
make-
Why do
tell
you
your
do?
radiologist. I know these days radiologists in a good institute would be considering that routine, but you should mention that.
Why? What's the advantage?
Ma'am, so as to
Next.
delineate the bony component from the soft tissue components of the cheek.
Okay. And biopsy, how do you do the biopsy? Wedge biopsy means exactly?
Ma'am, we take a wedge of tissue wherein we include the edge of the ulcer as well as the normal mucosa, which is just adjacent to the lesion, so that we take part of the ulcer and as well as the normal tissue for comparison.
Do you at any time note metastasis in the abdomen in squamous cell carcinoma, oral cavity? Is it common?
It's not. But it can occur. It's not common.
Why? Why it's not common? What is the mode of spread?
This is lymphatic spread, ma'am. Squamous cell carcinoma has lymphatic spread. So it is common to have involved the regional lymph nodes, more common than the systemic.
Okay, so usually in ultrasound abdomen, maybe for completion's sake you might do, but you don't really find anything in ultrasound abdomen, right?
Yes.
Okay.
The
In
other
this general
question
plan
is-
of
sorry. Yeah, carry on.
sorry, I'll just ask them a question, sir. In the general plan of care, is there something very, very important thing missing? You said you want to counsel the patient, you should know what to counsel. So would you want to do something very important before that?
May I ask question? About
Yeah.
the
Yeah, sure.
Dr. Vinay has asked. 1 second.
yeah. Okay.
Yes, Dr. Vinay.
No, my part is before that actually. It's coming to counseling. That's why. See, you all told that you will do HRCT chest. Agree to rule out metastasis. Why not do whole body PET scan?
That is the best option, sir. If the financial
So why not do that?
is limiting.
See, it's not finance or something. So when you are evaluating, you will be evaluating fully, no? Okay.
Yes, sir. Then PET would be a better investigation to rule out systemic metastasis.
And
No,
you all said
I
that.
think PET is not a protocol, a standard protocol in head and neck reconstruction in advanced disease, unless there are clinical features. As a routine, we don't do unless you have overt metastasis distant. Let's say you have an abdominal metastasis in these patients or a chest, then you can go ahead and do PET to see if there are metastases elsewhere. So what is the indication of doing PET?
Stage basically T4B disease.
Primary disease, primary T4 disease, you will do PET in patients.
Yes, sir. Then N3 states wherein there are multiple large nodes more than 6 centimeters, and
That is common in a patient with a head and neck. You might be having multiple nodes or bilateral nodes.
Bilateral nodes, yes, multiple.
Okay. Or if you have metastasis, distant metastasis is already there clinically, or let's say detected on other investigation, then there is a role of doing PET. Or patients undergoing recurrent disease or multifocal disease, means you have tumors in 2 different sites. These are indications of doing PET.
And one more thing is, you all told that you will do PopChick technique, CT scan, PopChick. So in PopChick technique, what you are looking for actually? What are the findings you are looking for? And why it is done? So what information we gather from that?
Sir, it helps to delineate the soft tissues of the cheek and from the bony mandibular tissue, the bony tissue of the face. So
Okay. So basically you say that cheek
improves.
is away from the bone.
Yes, sir.
So anything else?
So it forms a
Much more.
lucent area between the mucosa of the cheek and the gingiva over the mandible.
Yes,
So
that part is correct, clear. Anything else you seek for in Popchick technique?
it will clinically indicate if there's any adherence to adherence of the cheek as well.
Oh, that part you
infiltration
told.
of the walls, so as in the
See,
buccal
basically, Popchick technique also we assess thickness of the tumor, how close it is to going up to muscle or skin thickness, because that also will say how much to excise. Okay, fine. Continue, please. Dr. Biswas, you may take over.
Dr. Vinay, you were asking a question. Dr. Vinay is not there. So one
Hello?
more point. Vinay, you were asking a question, right?
Yeah, I was just wondering, like you're going to counsel the patient you've written. Are you anything? What specific thing should be mentioned here in your plan of care in respect to counseling or before that?
as in regarding the surgery, sir, or the diagnosis itself?
So you're going to counsel the patient. What are you going to counsel the patient?
So we will tell him regarding the diagnosis itself. We'll tell him that this is a malignancy, and there is he'll have to undergo surgery, and we'll try to reconstruct the lost parts using flaps from his own body, and preoperatively he will also have to improve the status of his basic lungs. We'll also ask him to do
All this, I agree with all this, but what would you want? You would want to know more information, right? So who's going to give you this information?
the patient attenders regarding the caregiving stuff.
You're going to tell that I'm going to remove your tissue, I'm going to reconstruct. What tissue are you going to reconstruct? Where you're going to reconstruct? Aren't you going to be doing that? To know that, you have to know something else before that.
The education level of the patient, whether he's able to understand.
Planning the discussion with the oncosurgical.
MDT.
Absolutely, that is majorly it should be there. Shouldn't it be there? Unless you know what the defect is, what will you know what to counsel the patient? So your multidisciplinary joint session should be there. Yeah, go ahead.
There is one more question. You have written building nutrition. So, I mean, if you get an oral cancer like this, would you be waiting to build nutrition? I know for completion you're doing it, but you should be clear.
The good point sir has got here. You very categorically mentioned in your history that the patient is having a lot of salivation, drooling of saliva. In this context, what very specific investigation or information would you want? In which other case do you have drooling of saliva in the oral cavity?
See, if there is tongue involvement, sir, then we can have drooling of saliva.
Right. So what happens in drooling of saliva? What is a very important issue that comes up?
So either it could be increased production of saliva because of the irritation, or the patient is unable to swallow the secreted amount of saliva.
So you're losing a lot of something. What is it that lot of something that you're losing in saliva? So when you're building up nutrition, you should be aware of that. In that context, I asked that.
Yes, sir. Alteration in the electrolyte balance of the patient, especially
Absolutely. You have a lot
in the patient.
not sodium. Your patient goes into hyponatremia. So you should ask whether there was any loss of orientation and disorientation in your history, because hyponatremia is very common. So you have 1.2 liters of saliva produced every day. So you have severe sodium loss. So you must replace sodium on a regular basis. Like in India, like we say, use an electrolyte packet every day. Okay, go ahead.
Okay, I think we can move on to the next part.
Yes, sir. So in this patient, CE MRI was done by the primary assessing team, sir. And this is the image. Sir,
Go back to the image. Can't we have a you have a pointer or something? Yeah, can you use that
Yes.
and tell
Yes.
us? Enlarge it. You're in the yeah. Yeah, that's fine. Whichever image you want to show.
Yes, sir. I think this one.
Yeah, enlarge it a little more. Yeah. Okay.
Sir, in this image, we can see a heterogeneously enhancing mass, which is seen in the right side of the cheek area. And here the periosteum appears to be a little inflamed periosteal covering can be seen. And I can make out there's a breach in the bony in the bony part of the mandible, cortex of the mandible posteriorly.
This is not a puff cheek
No,
view.
sir. Yes, sir.
How do you now? You only said that is how you differentiate bony versus a soft tissue lesion. So in this, to comment on that is very difficult because they are all either, because the opposite side shows there's no puff cheek.
Yes, sir.
There is erosion. You can make out erosion maybe, but it is very subtle if it is make out. What is overt? You tell us that first. There is a lesion in the soft tissue.
Yes, sir. Lesion in the soft
Extending from
extending from the midline, almost midline anteriorly. It is going up to the angle of the mandible posteriorly, and we can see the and up to the anterior aspect of the masseter.
Yes.
And the lesion is also involving laterally onto the, it is almost abutting the skin, destroying the muscle and the soft tissue of the cheek, sir.
Okay, now what are your negative findings? You said no, it is involving anterior border of the masseter. What about your medial pterygoid?
Medial pterygoid is free, sir. We cannot see
So you should say those negative findings.
Okay.
Is the floor of the mouth involved?
No, sir. The tongue, the
No.
floor of mouth, the
Yes.
medial
mention that.
pterygoid are free of tumor.
Okay, and you are saying that there is an erosion at the near the angle of the mandible.
Yes, sir.
Very difficult to say with this view, but possibly it may be there. Okay, anything else? You talked about an ulcer in your clinical diagnosis.
Yes, sir.
External ulcer.
Yes.
Where is that? You said an impending orocutaneous fistula. Does this corroborate?
No, sir. Actually, this investigation was done few weeks before the patient developed the ulcer, sir. So that we are not able to see in this film, sir.
So you should say that then.
Yes.
Okay.
Disease might have progressed. This was done earlier. So because this doesn't show. So either it is not there, your clinical findings are not correct, or this is not correct. One of them, there's a mismatch. Okay.
Did you mention the skin pinchability in the edematous area around the external ulcer?
Yes.
Yes, ma'am, it is not pinchable.
It's not pinchable.
No.
Okay. How much area?
What the edematous area?
Yeah, because externally cheek skin pinchability, how much area skin pinchability is not there? Because I mean to know how much skin is free. Because that's a finding I want to know. So did you assess that? Because cheek is a big tissue. There is an ulcer and there is an edematous zone. So where exactly how much area is involved? Because that will be your extent of resection externally, right?
Yes, ma'am.
Ma'am, this was the area, ma'am. Around the point of the prominence. Still here, ma'am, we were not able to pinch the skin separately. And in this upper part of the mid face and the lateral part, it was pinchable, ma'am.
And the area of induration?
Ma'am, induration was extending internally 5 mm all around. Here, around 1 centimeters all around over the
Surrounding the
external ulcer.
Okay.
So let's go back to the image.
Yes.
Okay, now this is at the level of the mandible. So that's in one plane only. Now,
Yes.
what about your superior extent? Do you have any views to show that? So you are basically saying that the cheek is involved on the right side from midline to anterior border of the masseter.
Yes, sir.
So what about its superiormost extent? Do you have any view with the upper
Do
alveolus?
you have any sagittal view or axial view? You're not put it together, right?
No, so this is the only film we got.
So what else would you want to see on this CT scan? One is the extent you don't have. What other things would you want to see? What other information would you want from the CT scan?
The tumor itself, sir, the extent, the structures which it is involving. Then we would also look at the lymph node status, sir. If there are any enlarged lymph nodes that are found in the draining area, sir, like the submandibular, the submental, and the jugulo-digastric group of nodes in the neck, we would see, sir. Then also
So
in this case, sir,
clinically,
because
you have mentioned that there is a level 2 lymph node as well, right? 2 by 2
Yes.
centimeters thing you've mentioned.
Yes.
So what specific thing in that context would you want to see? So level 2 large lymph node, right? So
Yes.
what specific lymph node information would you want?
It is level 2 is close to the spinal accessory nerve, sir. So we would want to see if there are any features of
Yeah. Any other more relevant structure that is relevant to you?
the PJV. No, sorry, not PJV.
So you need to see the
IJV.
because it's 2 by 2 centimeter, you need to see the perinodal spread and involvement of the adjacent large sites. IJV is sitting next to it.
No, yes.
Okay, go ahead. So what else? What other information would you have wanted? What information would you have given to the CT scan? Dr. Sir asked you about the puff cheek, right? What other information would you have put forward in your request to the radiologists?
Give all the views, as in the coronal and the sagittal views as well. Then
That is more for the oncology point of view, right? Anything specific from your point of view?
The status of the vessels of the neck, vessels of the possibility of the recipient vessels for reconstruction.
The oncological colleague will be more interested in those things, whether he can get around the vessels, whether he can give you a stump and all. But from your point of view, you mentioned some finding in which Dr. Gautam asked you whether the puff cheek was not done, and you had given some positive finding in that area.
the involvement of the periosteum, sir, the mandible.
So what would it urge you to request the radiologist in that situation?
So to ask whether it is just a periosteal reaction or is it
All these things are of relevance to your oncosurgical colleague, like we spoke. Anything in relation to your reconstruction?
sir, the foramen, sir, if the widening of the foramen could suggest neural
Which foramen? Which foramen?
the inferior alveolar nerve passes through the the mental foramen, widening of the foramen will suggest neural involvement, and hence we would have to go with the segmental mandibulectomy and probably do bone reconstruction from our side.
Very good. Wonderful. So would that extend your request to the radiologist?
Yes, we would ask for specific points.
You have to mention all this when you're presenting your radiology. The inferior dental canal has to be mentioned. Okay.
Would you ask them for special cuts, which are closely spaced?
Yes,
And
it's
some
close to the tumor, especially at that margin, sir, which is very doubtful whether the bone involvement is there or not. We would ask for finer cuts.
Okay, let's go ahead. We'll come back to it later. Let's go ahead.
So the report, the CMRI report read as follows: heterogeneous enhancing ulcerative altered signal mass lesion is seen involving the right gingival buccal sulcus complex. Mass lesion is infiltrating into the buccinator muscle. Posteriorly, it is extending into the RMT region and abutting the anterior fibers of the masseter and the temporalis muscle. Medially, there is no evidence of bony erosion, and lesion measures 7 × 6 centimeters, suggesting malignant neoplastic buccal mucosa lesion. So in this patient, also the primary team got FDG PET done, which showed no evidence of systemic metastasis. So, sir, the goals of our treatment would be to remove all the neoplastic tissue and reconstruction of the buccal mucosa, then reconstruction of the mandible to maintain the continuity, bone height, and osseous bulk, and also to create the facial symmetry and possibly and the possibility for future dental prosthetic placements, reconstruction of the skin over the right cheek, and finally prevention of the recurrence. To achieve the treatment goals, our surgical plan would be to do a wide local excision of the lesion with right hemimandibulectomy, considering the RMT involvement, and right modified radical neck dissection and left supraomohyoid neck dissection. So following the dissection, the tissue deficiency that will be faced with are: first, the right buccal mucosa. The defect will measure around 8 × 7 centimeters.
Just let me interrupt 1 second. Let us go to the excision back again before we come to reconstruction.
Yes.
Yeah, so you said wide local excision of the lesion. So what is going to be the extent of your excision?
So around
what is your anticipated? It is 1 centimeter from the individual margin, right? So what is going to be your defect in this particular patient?
Yes, sir. So in this patient, sir, our defect following the excision, the mucosal defect would be, sir, 8 × 7 centimeters, and we'll have removal of the right hemimandible, and the skin defect or the cheek would be, sir, 8 × 8 centimeters. And because the tumor is close to the commissure, we will also be losing lower part, the right lower lip, as well as the right oral commissure as well, sir.
I would have expected that you would have marked that out on the patient. Have you done that?
No, sir, I don't have any.
So is it possible to do it on this picture? Yeah.
Yes.
Unless you mark it out, then you don't know where it is going to be a lesion.
Yes, sir.
Okay, let's presume that is correct. But there are a lot of issues on this. Number one, you're marking a patient who's not shaved. So obviously we're not clear about the posterior extent. This might appear smaller than actually what is going to be excised. And this is the external defect. What is internal? What are you going to excise? Why have you talked about hemimandibulectomy? You said that the bone is not eroded.
Yes, sir. So, but on the reports, MRI report, they mentioned the RMT is involved, sir. So,
In one section, you said the bone is eroded, right? I remember you have shown.
yes, ma'am. In that section, it appeared like.
But she said the report does not say the bone erosion.
But in the CT scan, one area, the bone is eroded. And the.
Here it, yes, ma'am. Here it looks like it is eroded.
And clinically, do you have any free space between the gingivobuccal sulcus and the mandible? Alveolus? Is the ulcer is it fixed to the mandible, or do you feel any normal mucosa in between the thing?
No normal mucosa, ma'am.
So is it fixed to the mandible?
Ma'am, the lesion is continuous with the buccal mucosa. The sulcus is almost obliterated and is going on to the gingiva over the mandible. There is no intervening normal mucosa.
The question comes, when do you do a mandibular resection?
Yes, sir.
Why don't you do a marginal mandibulectomy?
The current practice is for the current practice is to do a segmental mandibulectomy in any patient showing a positive radiological study. So in this patient, when there is a positive study indicating
that is correct. If there is a bony erosion, which is according to the report, it is not there, right?
So in the
It is
report, they
there.
mentioned RMT is involved, sir. So that's.
RMT is involved, but
Yes.
RMT involved is a different story than bony erosion.
Okay, sir.
You said that the tumor is extending into the anteborder of the masseter.
Sir.
There is no bone erosion in the report. You yourself said that there may be a bone erosion at the posterior part.
Yes.
So what the question what is being asked is, what are the indications for a mandibular resection, segmental resection? Why don't we do a marginal mandibulectomy?
Any clinical involvement of the bone that is identified.
So that is one. Yes, agreed.
Of
If there is erosion, but that erosion is sort of iffy in this CT scan.
Yes, sir. And any involvement of the floor of the mouth will necessitate for a mandibulectomy.
Whole of the mouth.
Segmental mandibulectomy. And
So obvious involvement of the bone marrow, sir. Involvement of the neural.
Those are overt cases. So what was just said is, if you do not have a healthy mucosa of 1 centimeter between your tumor and the mandible, and it shows erosion, then you have to do a segmental mandibulectomy.
So, yeah, the principle of oncology being, you go in the soft tissue, like in head and neck, you go 1 centimeter beyond, and in the depth, you go 1 plane beyond, and on the bone, you go 1 tooth beyond, and on the in the intraoral cavity, you go 1 zone beyond. So, like what sir is asking, what is the thing? Why are you not doing a marginal mandibulectomy? Can you give that answer? Or when will you do a marginal mandibulectomy? Probably a positive answer. Let us question you. When would you do marginal mandibulectomy?
Yes. So when the tumor is away, it's not involving the bone, it is away. And when we have to give 1 centimeter margin, when it kind of overlaps onto the gingiva of the mandible, then we can do the marginal. So just to give the clearance, we can do the marginal. So when there is no very covert like involvement of the bone.
As ma'am was suggesting, a small narrow band of normal healthy mucosal tissue lying between the tumor itself and the tumor's induration and the bone may be dealt with by a marginal mandible.
But do you see any healthy mucosa in between the ulcer and the mandible? No.
Not in this case, ma'am.
It is fixed to the mandible.
Lower GB sulcus is involved, what madam is saying.
Yes, yes.
In that case, segmental.
What are the modes of spread of the tumor to the mandible? How does the tumor spread to the mandible?
Ma'am, a direct or contiguous extension of the tumor itself through the secondly,
could be perineural, ma'am. Through the nerve, it can enter to the bone. Then also through vascular spread, ma'am, like bloodstream mediated by the bloodstream. The tumor cells can enter the bloodstream and lodge in the marrow.
So in this patient, you don't have a healthy margin between the ulcer and the mandible. And radiologically, it is extending to the retromolar trigone. What are the structures you have there in the retromolar trigone? If it is involving the retromolar trigone, the oncologists say we have to go for a segmental mandibulectomy. Why do they say that most of the time?
In RMT, the mucosa is just over the bone, ma'am. There is no other structure which can prevent the bony involvement. So there is bony involvement very early in the onset of the disease. So hence we assume that bone is involved and we proceed for segmental mandibulectomy. And also in RMT, just lateral to it, we again have the masseter and our muscles of mastication like temporalis as well as the medial pterygoid, which will be involved, ma'am. So then again, the resection becomes very extensive because we have to remove these structures as well.
So in this patient, radiologically, whether there is an erosion or not, there is a dilatation of the neural canal or not, whatever it is, the oncologist will go for a mandibulectomy, right? I mean, that's what the routine practice. We say in our center, oncologists take the decision of resection. Dr. Gautam Biswas, maybe I think in your center you do it, but most of the time, these kind of cases, irrespective of the CT, they go for a mandibulectomy. So how much mandible will be removed? That's the question. So whether it's a segmental or a marginal. So that's what sir is asking. Are you going for a marginal mandibulectomy? If it is, what are the indications for marginal mandibulectomy? Can you do it in this case?
With RMT involvement, we would say no, ma'am. If RMT is not involved with the present, the films, whatever we can see, where there is no obvious bone invasion, ma'am, in that case, we could do marginal mandibulectomy.
You said that you're going to do a hemimandibulectomy, right?
Yes.
So what is a hemimandibulectomy?
So hemimandibulectomy involves removal, yes, sir, of the mandible from the canine up to the even the ramus. We just spare the condylar process of the mandible, sir. So we remove both the central as well as the lateral part of the mandible, sir.
Which classification is there for segmental mandibulectomy designation?
Sir, we have the Boyd's classification, sir, which classifies it as central, lateral, or hemi-mandibulectomy. Then we have the new Brown's classification, sir, where there are 4 classes.
Talk about one. There are many classifications.
Current practice.
One are you talking about? Which one? No, you can use any one that you are convinced is good enough.
So we
Which
can.
one are you following?
So the Cheng's classification.
What is that?
Sorry, sir.
What is that?
Cheng's classification actually categorizes the hemimandibulectomy in terms of the involvement of the hemimandible itself, the central segment or the lateral segment. It could be type 1A, which is central, type 1B, which is lateral, type 1C.
These are subgroups. So
yes,
what is hemimandible? Hemimandible is from the condyle to the midline or midline.
Okay. To the midline. It's not canine, to the midline.
The midline.
Midline.
So are you going to do that? Because you said hemimandibulectomy.
Yes, yes, sir.
From the condyle will go and up to the midline you will remove.
Yes, sir.
Why do you want to remove the condyle?
We will spare the condyle, ma'am, because retromolar trigone is involved, so we'll go up to the angle, ma'am. So we have to give.
So the angle is fine, but then beyond the angle there is a ramus and there is a condyle. What do they usually do? The condyle, if you remove, what's your problem? From our point of view, reconstruction point of view.
The TMJ will become unstable, so we will not usually.
TMJ, there is no TMJ. You have removed the condyle.
Yes, so we do not remove the condyle.
The reconstruction. In this patient, if you look at your CT, you don't need to remove the condyle. There will be a sizable portion of the ramus also left, right?
Yes, so we can use it
Medial
as.
pterygoid is not involved. Lateral pterygoid is not involved. You are not going into ITF clearance. Infratemporal fossa, you know that clearance is not required.
Yes, sir.
because you have to anticipate the defect. Dr. Vinay asked, unless you know extent of defect, how are you going to plan what you're going to reconstruct? Chalo, let's move, otherwise we'll not finish like this.
So anyway, let them complete the extent of the bony defects.
Yeah. Say, so what is your excision? Let's go to the CT if you can. Yeah. Now tell us what you're going to remove. Enlarge it a little bit.
Yes,
Can you
so
mark out?
so we would because the anterior extent, it is almost come to the midline, so we would give 1 centimeter here, and we would do a matlab for the bony resection, sir. We would do the bony resection here, and
Slider means it will basically be crossing the midline.
yes, sir, this is slightly crossing.
Wait. So you said no, it is up to the midline. Let's say the tumor is up to the midline, so you'll be crossing the midline.
Okay, sir. This is the midline, so we'll be going from the midline, and on the to give clearance posteriorly, we will we will take up to the ramus. We will not completely remove the ramus. We will take centimeter around the above the RMT, so that we can give the clearance.
So you will keep the medial pterygoid or not keep the medial pterygoid?
Sir, we will have to remove the medial pterygoid. The angle will be gone. We'll remove the medial pterygoid and the masseter. Masseter, the tumor is abutting the masseter, so we'll remove the masseter and the medial pterygoid.
You will remove the masseter from its origin. That means the zygomatic arch. That's what you're saying, or
Not
you're
the
just going
insertion,
inside?
sir.
So it's part of the masseter, right?
Part of the masseter at the point of insertion, and
You're going to divide the masseter up to the tumor level. So you'll take a margin of a centimeter beyond the posterior margin of the tumor. So in this, according to the CT,
yes, sir.
Will be at the level of the ramus.
Yes, sir.
So the incision can be, these patients are, what sort of excision is done in the ramus? My question is, in the ramus consists of the condyle, the coronal
Sorry
process.
to intervene. 5 minutes left, sir, for the
sorry.
discussion.
So then let's go to the plan.
Yes, sir.
Let's go to the plan. Let's go to your reconstruction plan, right?
Yes, sir. Yes.
Because that needs to be addressed.
Yes. So, keep saying.
So to achieve the reconstructive goals, our plan is to do a left osteocutaneous free fibula flap for the reconstruction of the bone and the oral lining. And for the external lining, we'll be using a pedicled deltopectoral flap for the reconstruction of the skin.
So why have you chosen that?
Sir, the fibula offers a sturdy bony stalk of an adequate length, and it has a reliable vascular pathway which can be utilized for us to harvest it. And it also provides a sort of the height that is required for the reconstruction of the mandible with the utilization of osteotomies. And it provides also the vascularized skin paddle, which can be used for the oral lining. And externally, we'll be using the it's a composite defect for which the external skin reconstruction can be done by the utilization of a deltopectoral flap based on, again, reliable vascularity and proximity to the lesion, to the defect.
That is.
Can I just ask one question? Oh, hello.
Yes,
yes, please.
Can you just tell your defect, the extent of the defect in the oral mucosa, in the mucosal side?
Yes,
Posteriorly, how much because you have to give your flap inset. So if you tell the extent of the defect externally and internally, then we can discuss the flaps. Why do you need 2 flaps, or is it 1 flap sufficient, like that? So how much is your defect internally and externally?
Internally, the mucosal defect is around 8 × 8 centimeters.
No, not the 8 and all. Posteriorly,
picture.
where exactly you are going to give the insert, and inferiorly and superiorly and anteriorly, what are all the structures you are missing? Externally also. Flaps we can discuss, but you
Yes.
can just go back to your diagram and just describe your defect.
Previous.
What are the structures you will be missing? Internally, mucosa, where exactly you are going to give, show the intraorally. Yes.
Yeah,
Posterior. No.
The part of the lower lip, 1/3 of the lower lip, and
Yeah.
part of the commissure will be involved intraorally.
Mm.
Posteriorly, it will be from with utilizing excision of the mandible as well to the ramus with the lateral segment of the ramus, lateral segment of the mandible, therefore exposing the insert will be at the floor of the mouth itself directly, and superiorly it will be up to the about 1.5 centimeters below the superior gingiva buccal sulcus. Superiorly,
Superiorly, it will be gingiva-buccal sulcus.
yes, ma'am.
And posteriorly, beyond the retromolar trigone, almost
beyond the armpit, yes.
palate, soft palate.
Up to the tonsillar pillar.
Posterior tonsillar pillar, and above it, I think it's almost like palate. Some amount of the palate also you might be losing. Medially, floor of the mouth, because you are removing the mandible. So it's not the exact defect you will be measuring. You will be measuring the skin paddle, which is needed to cover the bone also. So it's not just 8 centimeters, it will be more than that. So floor of the mouth, and anteriorly, it's almost 1/3 of the lip is gone below, and above also 1/3 of the lip is gone, and the commissure is gone.
Yes.
And now go externally. External skin. So it's a
Ma'am, externally, again, a skin defect of around 6 centimeters into 7 centimeter defect will be created, where we will be losing the majority of the right cheek, and the inferior border will lie on 1 centimeter above the lower border of the mandible, and we will be losing the lateral third of the lower lip as well as the commissure.
Upper 1/3 of the lip, lower 1/3 of the lip, and commissure and external skin, and internally the whole of buccal mucosa, almost floor to the floor of the mouth.
Yes.
So now let us go to the flaps. So you know how much is the skin. It's not the. Yes.
So part of your upper alveolus is also.
Yeah, it will go actually. Yeah, it will go, and you may have to give the insert to the palatal mucosa.
Yes.
So your plan is osteocutaneous fibula. So why can't we do only one flap? Fibula skin is not sufficient to do the internal and external and upper lip and lower lip.
Yes, ma'am, it can be used, ma'am. When we marked out the flap, ma'am, to consider both the mucosal defect and the skin defect, the flap marking was it was large, and we were crossing the posterior midline. So hence we thought we would use the skin paddle of the free fibula flap for the mucosal lining, and we would do another regional fasciocutaneous flap for the skin cover.
So you have planned a DP flap, which is a staged procedure, right?
Yes, sir.
So you're going to leave a raw area under the flap, which will be exposed for at least 3-4 weeks till you detach.
Yes,
sir.
May I ask one question?
Yeah.
May I?
Yes, sir.
Say, why you decide that you will do a fibula flap? How you prioritize reconstruction? What is the main aim especially in head and neck cancer treatment? What is the first goal? Goal of treatment.
The complete removal of the tumor mass with adequate margins.
That is no. What is the aim?
Reconstruction. Aim.
What is
reconstruction?
No, not reconstruction.
So
what is the aim in cancer treatment? Complete the treatment.
Yes, sir. For
No? Complete the treatment. And all reconstruction modalities, whatever we do, that should supplement that.
yes, sir. For the adjuvant treatments of radiation and the
So
space.
that should be completed at the earliest.
Gotcha. Yes.
Okay. So then what else you will consider in head and neck reconstruction?
So to rehabilitate the patient in terms of the function, that is masticatory function as well as.
No, I don't think, that is. Really, you have to consider patient should have an open mouth so that can be inspected. So airway is not compromised. At least these things we will consider. And also we do a treatment that is good primary healing.
Yes.
So that adjuvant treatment can be started early.
Is possible.
I think you will keep. So there is definitely when you talk about ideal complex reconstruction and what is the appropriate reconstruction. I know that as a plastic surgeon, we all can do a complex reconstruction, but what is appropriate for the patient, that should be considered.
Yes, sir.
That's why madam was also asking, why can't you do one flap?
Yes, it can be. Yes, it can be
So
done.
many times you have to cut short the duration of treatment so that adjuvant treatment can be given also.
Yes.
See, do you think doing a mandible reconstruction will do good to this patient? Upper jaw is gone. Then mandible is gone, Then why you are doing a reconstruction of a mandible reconstruction if you do? What advantage you will get?
What is the stage of the disease for this patient?
It's stage 4.
Stage 4.
T4A and 2B stage 4.
So what is the 5-year survival rate in the stage 4 disease in oral cancers and also the recurrence?
With all modalities, ma'am, I think it is around 30 to 40%.
So in such situation, as Balyar Singh sir said, don't you think the treatment, we have to complete the treatment as early as possible instead of doing the stage flaps, a big free flap, additional to that pedicle flap, we wait for 3 weeks, divide again another week, and it might heal or it might not heal. So why is it possible to complete the whole reconstruction in one stage?
Yes, ma'am. We could use the skin paddle of the free fibula itself and fold it on itself, deepithelize an area so that we can cover the mucosa, give an inset as well as cover the skin when it's possible.
Yeah, that's possible. Suppose if the patient is having good perforators and you can take a very big skin paddle, it's possible to take a very big skin paddle and externally and internally also you can do, because the segment of bone defect is not really very big. It's big actually. It's going beyond the midline and also to the ramus. So it's a complex reconstruction. Even single fibula might not be possible. So ideally you need the 2 free flaps or a combination of fibula and PMMC maybe to complete that thing. Or else defer a bony reconstruction and do only soft tissue reconstruction. So the options are like, depends on your center's infrastructure, expertise, and also patient's comorbidities and the disease status. So it's always important to see the disease and also plan accordingly.
Yes, ma'am.
So this is both Darshan and Sonika.
Yes, sir.
Pertinent question is, because you all are presenting in a big competition, you know that the defect is composite, right? You classified your defect already before, as a right hemimandibulectomy. So obviously you know that the right entire hemimandible is going right from wherever midline to the condyle.
Yes.
In this context, this is your plan, as what we all can see, that you have planned a fibula for a no condyle, ipsilateral condyle mandible.
Yes.
Is it justified that where will your where will your fibula articulate with? Is it going to be suspended in the air like a cantilever? Is that what you want? And then you need one soft tissue flap for the lining and then one soft tissue flap for the cover, which you are not finding enough. You've got 3 perforators you have marked. So would you want to justify yourself with this fibula, which is just sitting there doing nothing? Or would you want a single composite bulky flap, soft tissue flap, like Dr. Amrish is saying, go early for radiation or composite adjuvant therapy? So this plan is for a hemimandible defect, as I know. That is what I'm trying to say. So is it justified having this fibula there?
They change their plan. I think they're not doing a hemimandible. They're keeping a part of the condyle and ramus.
So, but they have planned the entire, they're in theater, everything is done, and they've gone ahead with this. This thing should have been done at the level of planning itself, what your exercise. This is why you have landed up in a soup in which you are changing your plan in between a case. So this
sorry to
no, see, we'll support you have to support whatever plan you do with your arguments. There are a variety of plans and approaches to this, and it will vary from center to center, experience as discussed. But you have to support your plan, or you have to have a plan B. Right?
In principle,
You
yeah. In
support your
principle,
plan.
what would your approach be?
the time is over for this session. This discussion
No, 5 minutes more.
continued in panelist time, sir.
Madam, 2 minutes I'll take. Few things they should know. May I ask one question?
Yes,
Yeah,
sir.
carry on.
Okay.
See, in many conditions, we know that mandible reconstruction can be done, but is not done. Are you aware of such conditions? When you will not do a mandible reconstruction, but it can be done, but one will not do. See, we all, when we talk about the defect and what is the tissue loss, all we talk about, and you try to replace one by one. So that's how the bone comes, then the skin comes, like that. But we should give a consideration also to the mouth opening. If the mouth opening in the beginning is less and at the end of the excision mouth opening is less, so what does a reconstructor mandible would do? Probably because if you do a mandible reconstruction, mouth opening is going to further reduce. So which is not a good idea. You also give a consideration for this. And second time is sometimes like uncontrolled diabetes, because you are dealing with oral cavity. So these sites are also potential infections are also there. If you have not controlled the diabetes or anything, then can be also infection, and usually may lose the bone also. At least these 2 conditions I know where I won't do. Okay.
Also for lateral segment mandible, sometimes you can just do a soft tissue.
Yes,
Of course,
that
there are
also.
disadvantages, but these points what Dr. Balayar Singh is saying, you should know for the sake of discussion.
Especially, I think for this kind of disease, advanced disease stage 4, lateral, just it's a lateral segment defect, we can leave it alone.
Yeah.
The only positive point here is it's going a bit beyond the midline.
Midline, yes.
That's a
So
point.
there are ways to approach that also. You can leave the lower border of the mandible if that is not involved in any way beyond the midline. That way, the central segment gets spared, and you can do the rest by bony reconstruction. But I think we are short of time. We'll have to move
just
on.
one last question quickly.
Yeah.
One last, just a summary. What would be your other plans be if you can just summate them? This was your first plan. What are your other options before we wind up on this?
Sir, first thing we would try to cover both the inner and outer lining just with the free fibula flap, sir. Else, we could use a bipedical PMMC without doing the bony reconstruction. We could do bipedical PMMC. And
So what's the problem with bipedical PMMC for this patient?
yes, it becomes very bulky, sir.
No,
And
no, not
we
that.
cannot bring
This guy is not that bulky. Forget bulk. Anything else?
In
the
this,
radiation, we might
Radiation, no. The extent of your defect, it is going up to the palate. So reach of your PMMC is so rest is, of course, there are other issues also. But
So,
there will
have you
be
marked
value.
them? Have you marked these in your presentation, these flaps on the body? Can we just see them quickly?
Yes, sir. Sir, because we planned DP for DP flap for skin cover, sir, we had marked the DP and we have also marked the PMMC skin cover itself. Thinking we could use either DP or PMMC. Actually, sir, we reserved a PMMC enough. We didn't put it as a first option because we thought if there is if the free fibula fails, then to cover the internal lining, we will not have any other option but for the PMMC. So we chose DP over PMMC for the covering of skin in first place.
So what about PMMC? DP as a backup and PMMC as your external cover? What's the argument against that?
Sir, if the skin paddle of the free fibula,
Outside.
yes, sir. If that goes, then
Your fibula remains okay. Instead of using DP, use pec major as your external. What is your argument against that? You understand my question?
yes, sir. As
Use
in
the
why?
PMMC for the outer skin and use free fibula for the inside.
Yes, sir. So that is
Right.
that
Yes, sir. So at a later point, if we lose the skin paddle of the
No,
free
I'm
fibula,
not talking about losing primarily.
yes,
Then
sir,
it is a
then we will not
one-stage
have an
procedure.
option.
we don't have a backup option to
cover the
inner lining.
exposed bone, sir.
if at all
that's what we
our
thought.
primary plan were to fail.
Exposed bone means?
So if the skin paddle of the free fibula is gone, sir, if we lose that, then we'll have to give another flap for intraoral
Skin
cover.
paddle lost, so the whole fibula lost.
If there is loss of the whole of the
Whole fibula, then you'll have to do something else. Anyway, let us not move into that. That's a different quicksand territory. If you lose your fibula, you can't do a pec major only. So you want to keep pec major as backup for
Yes,
your, in case you fail. Okay. Okay. But usually the protocol these days are, if your free fibula fails, then you can do another free flap. Maybe a soft tissue free flap if you're planning. Doesn't matter. Let's move on. Any we can. What are the timing says? Can we move on or what do we
Yes,
do?
sir, we have to. And other
We have
teams
to.
will ask questions to this.
Okay.
team.
Okay. Let them quickly ask.
Yes,
And
sir.
then
Team 1 Madras Medical College.
we have 15 teams, 16 teams.
Yes, sir. Team 1 Madras Medical College, do you have any questions to ask for the presenting team?
Teams, be fast in asking.
Otherwise, they should have put it in the chat box. We could have easily gone through.
Okay.
Team 1.
Moving to team 2, Jipmer Pondicherry.
Good evening, ma'am. How will you monitor the free flap after in the OT? And what are the protocol you will follow in monitoring the free flap? And what you will do if there is a congestion of the flap?
During a post-operative observatory period, we will do the flap monitoring every hourly, wherein we will see for the color of the flap, the turgor of the flap, and also the bleed on pinprick. And also we could do the flap
monitoring,
sugar monitoring,
peripheral sugar monitoring,
and Doppler signal.
Either we can use a the handheld Doppler by leaving out a handheld Doppler, or utilization of a laser Doppler, placement of an
What are you going to do? You have to talk about what you're going to do. You don't list all the
We will
procedures.
be clinically in our institution. We will have the only option of
observation, sir.
And
the sugar
intraoral. What you're going to observe? Intraoral, very difficult.
Yes, sir. So we do the pinprick. Yes, sir. Pinprick and sugar monitoring.
Or is it a scratch?
It's a needle scratch.
Sorry, scratch.
Not pinprick.
Sorry.
Why you don't do a prick?
So then we get blood supply from the deeper. Then we
Deeper
want
portions, you will not get blood,
yes.
no?
Yes.
Okay.
Yes.
Any other questions? Yeah.
And if there is congestion, then we would take the patient to the OT, OR and explore as early as possible.
Yes.
Thank you. Thank you.
Release the procedures.
Questions from team 3, KGMC Lucknow.
Hi. What is the extent of deltopectoral flap and what is extended DP flap margins?
The deltopectoral flap usually it can be taken up to the groove, which is the axial pattern, and after the groove up to the posterolateral border of the deltoid muscle is the random pattern flap. So we'll have to do the delay to do the extended DP flap.
In the extended up to where you can take in the arm?
Up to the posterolateral border of the deltoid muscle.
Next team.
Okay.
Good evening. This is Stanley Medical College. So my question to you is, before doing a free fibula flap, what will you rule out or what will you look for?
In the foot, we'll do the foot Allen's test and see the perfusion of the limb, and it is basically to see the flow in the peroneal artery, and in a very rare case scenario, we'll also have to rule out the peroneal magna condition, wherein the major supply of the lower limb would be the peroneal artery itself, for which CT is necessary. CT angio.
Okay. Okay.
Team 5, AIMS New Delhi. Questions from team 5.
AIMS New Delhi.
Yes.
What are your goals of mandibular reconstruction?
The first goal is to provide the integrity, give the bony reconstruction, and return the bony continuity osseous bulk. And also next is to give the function, that is to maintain
establishing the occlusion and as well as to possibly rehabilitate the masticatory function. Thirdly, to provide the external cover.
And lastly, the aesthetics also to maintain the facial symmetry.
And oral continence also you have to restore. You missed that. Oral continence is important. Yes.
Not through the mandibular.
Okay.
Next.
Thank you.
Thank you.
Team 6, Bangalore Medical College. PGs from Bangalore Medical College. Okay. Moving to team 7, CMC, Vellore. PGs from CMC, Vellore. Okay, fine. Moving to team 8, Safdarjung Hospital, New Delhi. PGs from Safdarjung Hospital, New Delhi.
Good evening. What can you tell me about the blood supply of free fibula flap?
The free fibula flap has two major blood supply. One is the endosteal supply, which is through the nutrient artery, and the other being the periosteal supply. Both are basically coming from the peroneal artery. So
it is the Cormack and Lamberti classification type D, wherein there is an osteomyocutaneous flap is supplied by the single axial vessel, a single large axial vessel.
And the second part of my question, where do you make the osteotomy cuts in fibula?
We will take we'll leave 6 centimeters on the proximal as well as the distal aspect of the fibula, so as to maintain the integrity of the knee as well as the
to prevent injury to the common peroneal nerve proximally, 4 to 6 centimeters is spared proximally. Distally, to prevent the instability at the ankle joint, especially in case of tibiofibular fusion, we leave again a 6 centimeter stock of bone.
Okay, thank you.
Thank you.
Next, team 10 from PGs from Gandhi Medical College.
Okay, hi. I would like to know, after mandibulectomy, how would you like to adjust the height of the fibula with respect to the placement of the dental implants?
So So with respect to the native mandible, it is kept at a distance of at least about 1 centimeter from the lower border of the native mandible, so as to provide a sort of the adequate alignment for the placement of an osseointegrated dental prosthesis.
How do you adjust the height of fibula?
It is kept at a distance of 1 centimeter above the level of the lower border of the native mandible.
That is one way of doing it, but there are various ways of doing that.
Yeah.
So you put it 1 centimeter, then the lower border there is a gross mismatch.
If there is too much of if it is too incongruent, we can consider double barrel fibula placement.
Yes,
Which is not indicated in this patient with restricted mouth opening, as Dr. Balyar Singh said. Not even double barrel, maybe you will have an issue with doing a fibula itself with a restricted mouth opening.
Yes, sir. Thank you.
Thank
you. Team 11, Kilpauk Medical College.
Good evening. Can you please tell me about osteoinduction, osteoconduction?
Yeah, so these are the ways in which the bone heals. So osteoconduction is a process wherein the bone graft that we put acts as a scaffold over through, or rather over which the osteoblasts grow, and they do the osteogenesis. But for osteoinduction, here the segment of the bone carries with it the progenitor osteoblastic cells, and also produces the bone morphogenetic proteins, BMPs, which will promote more mobilization and more of recruitment of the new osteoblast for bone formation.
Thank you.
Next, Team 12, PGs from MAMC, New Delhi.
Hello. Can you tell some indications of adjuvant radiotherapy?
Sorry, we didn't get you.
Can you tell some indications of adjuvant radiotherapy?
Okay.
In the indications include any extranodal. Am I audible?
Yes, sir.
Yeah. Any extranodal disease, any involvement of neural structures, vascular structures, or small disease, neural structures, vascular structures. Any
a very extensive disease involving the infratemporal fossa and involvement of the masticated space,
N3 disease,
and involving the base of skull and vascular involvement.
Okay. Any extracapsular spread and influence also?
Extranodal.
Thank you.
Team 13, PGs from Nizams, NIMS Hyderabad.
Yeah, hello. What are the indications for vascularized bone graft or flap in mandible defects?
Indications of vascularized bone graft
or flap in mandible defects?
Indications as in to again provide the structure, maintain the integrity of the mandible, maintain
all the goals of reconstruction for mandible, including the reestablishment of the continuity, to provide for the functional aspects of the mandible, as well as to provide facial symmetry.
And a fibula, as in if you're asking why fibula is preferred, then it is a pretty long bone and a strong bone, which provides good amount of stump, and it is having predictable vascularity, and it's an expandable bone which can be used for reconstruction for the mandible.
Say about it's only 4 centimeter defect and it's a benign disease. So do you still go for a vascularized fibula?
No, ma'am. We can use non-vascularized bone graft for defects which are lesser than 6 centimeters.
That's the answer expected from you. What is the indication means? The indication is in cancers, post-op radiation is given, and the defect is more than 6 centimeters. So that's the answer he is expecting, right? I think so. Okay.
Thank you.
Okay. Team 14, PGs from Ganga, Coimbatore.
what is virtual surgical planning and what is the role of what is CAD?
Sorry.
Rumi, you are not
What I
audible.
heard was
Your sound is breaking. Can you repeat the question?
Hello.
Yeah.
Yes, sir. What is virtual surgical planning and its role in this case?
You can place the question in chat box. Meanwhile, other team will ask the question.
Okay.
Your voice is breaking.
Team.
Good evening. My question is, what is virtual surgical planning and what is CAD-CAM?
CAD-CAM is computer-assisted mapping and designing, where preoperatively we will do a three-dimensional study of the mandible of the patient. We make a three-dimensional model beforehand so that we can decide preoperatively itself what the osteotomies are going to be and what are the angles. Basically, we can plan the osteotomies beforehand.
You also plan resection beforehand.
Yes, resection and yes.
So what are the two parts of a CAD-CAM? One is the resection. So what is that portion of CAD-CAM which involves resection? So you need a cutting guide, right?
Okay. So we haven't seen one, but
But you have to read it. You don't have to see everything. Okay. And then you do a reconstruction by doing marking out the osteotomies in the fibula, right?
Yes.
So you have a head and neck model, you have a fibula model. Okay.
Questions from team 15, Ames Bhuneshwar.
Hello, good evening. Can you please enumerate the different types of mini plates and screws and based on their composition and also some of the salient features of them? And secondly, what is the usual size and profile of the plates being used for fibula fixation?
we usually use the mini plates. I'm not very sure of the types.
Based on their composition.
Yeah, basically they can be made of titanium material, or it could be the stainless steel mini plates as well. And
some salient features to differentiate them.
Titanium plates are usually colored and they're lightweight.
They mean to say what is the properties which will differentiate them in terms of their use.
Basically, pros and cons of each.
Yeah.
Too long a question.
Titanium is not utilized.
Not
Team
sure.
16.
Not sure.
In terms of reconstruction of the fibula with the plating, we utilize using a CAD-CAM. You can utilize a titanium plating with the nascent or native mandible that is present and use that to create a plate or reconstruct the fibular components. I'm sorry, can you repeat part of the question? Second part.
What are the types of plates for mandibular reconstruction?
So there are the reconstructive plates which can be utilized, which are commonly utilized, and there are mini plates can also be utilized with the prerequisite that there is already the fixation with an internal maxillary IMF or internal maxillary fixation already established. That is, it cannot be done alone.
Okay. I had asked just the types of mini plates, not exactly recon plates and mini plates. Based on mini plates, as you said, we have, as you said correctly, there's stainless steel titanium. Titanium obviously is the current material of choice. Although they are expensive, they are more malleable and they are more inert in comparison to the previously used stainless steel plates. And thirdly, we also have bioabsorbable mini plates nowadays, which are preferred to be used in children. They are made up of polyglycolide, so they are used sparingly. Usually we use 2 to 2.5 millimeters screw diameter.
But you don't use these bioabsorbable plates for a malignant lesion, right?
Yes. Yes, sir.
Next question.
Next, final team, team 16, Vigis from AIMS Rishikesh.
Good evening, everybody. My question to the participating team is, do you know what is anti-gum deformity?
Yeah, when whole of the mandible is removed, or rather, when the whole of the mandible or it's removed, then it leads to a deformity where there is no vertical height of the mandible. Absolutely, it is taken from a comic character known as anti-gum, so it's called the anti-gum deformity.
Actually, it is referred to as the anterior mandibular defect with an absent chin, which gives a retrognathtic look. And yeah, you're right that it comes from a cartoon character.
Yes.
Thank you.
Thank you.
And become created by between 1917 and 1959. Interesting.
How many teams are absent? Rohit?
Team 1 Madras Medical College is absent. Hello, am I audible?
Yeah.
Team 1 Madras Medical College is absent, madam. And team 11 Kilpauk is absent. And there is one more team, ma'am. CMC Velo, team 7 is absent. Team 6 Bangalore Medical College is absent.
Bangalore
1, 6.
I think it's there.
Sorry, madam. 1, 6, 7, and 11.
We'll move to the next session.
Yeah.
Spotter. Project the spotter.
So what is this? This is going to be a spot.
Normal pages, withdraw your sharing. Rohit will share the next session. Next session is the spotter. They have to diagnose and tell the treatment.
Time?
Time is allotted 10 minutes. It's mainly discussion.
10 minutes. Spotted. Okay.
We'll start, ma'am. Spotter is the case of a pinoscrotal type of hypospadias. Ma'am, it is a pinoscrotal type of hypospadias without any features suggestive of DST. Here in this case, the penis there appears to be with or without chordae. There appears to be no the penis appears to be normal in appears to be grossly normal with no visible chordae that can be noted on the patient, and bilateral scrota are present, which seem to be normal for which seem to be fully developed. There is a central hypospadias, or rather the meatus located between the two scrota, suggestive of a pinoscrotal hypospadias.
And the preputial skin is intact, suggesting the patient has not undergone
possibly does not undergone
circumcision.
circumcision or has undergone
As in the preputial skin is preserved.
The glans itself appears to be conical in shape, and yes.
How do you say there is no chordae? This view will not give you a clear picture.
Yes.
Yes, sir.
You should have asked that we need a lateral view. If it is obviously we are not seeing a patient, we have to see from a photograph. Number one, status of the glands.
Yes, sir. Is it
there
flat?
a urethral meatus there, not there? I can't make out from this picture. We are presuming that it is not there.
It's not there.
Can you see?
I am
Can
not.
you make out?
No, I'm.
So when you can't make out, you should ask. I need to see the glands closely. I need a more enlarged picture. So in this case. So there is a apparent penoscrotal hypospadias, and you can make out that there is a part of the prepuce on the dorsal aspect and lateral aspect intact. Ventral, I'm not clear.
Yes.
Or is it a reconstructed hypospadias?
Yeah, so there's so many things.
Sir, there is a possibility
So
that
what doctor?
there is a possibility that the patient we cannot glean from this picture.
So
So
what Dr.
presuming it
Vinay
is a
asked you-
penoscrotal hypospadias.
Yeah, can I carry on?
So presuming it is a penoscrotal hypospadias from the picture on the top right, you know, where the hand is holding the scrotum and playing it apart, you can see a raw area. How would you approach it? In the OPD, what would you see the patient and tell the patient with the parents?
When the patient presents to us, when the male child is brought by the parents, we with the complaints of soiling of the pants while micturition and obvious malposition of the meatus, we would tell the parents that the patient would require surgical correction for the replacement of the normal positioning of the urethral meatus, the urethra, as well as staged reconstruction of the urethra as well as the stage reconstruction of urethra, and if Cordy was present, prior release and management of the Cordy as well.
And we would also explain about the high chances of infection and fistula formation,
and the
multiple
recurrence of the same issue even post surgery, the possibility of creation of what is known as a hypospadias cripple, that is someone who suffers from recurrence beyond 3 surgical managements, and also possibility of shortening of the length of the penis and some dysfunction in some sexual dysfunction.
You need to
So you
examine.
want to really scare the patient that he might become a
I'm just explaining
it's a fresh patient. Patient came to you first time to the OPD. You should explain that he needs these many procedures. These are the procedures, the first procedure, second procedure. But you don't tell him that he'll become a cripple. I wouldn't tell. I don't think anybody would tell.
I would also, something I forgot is I'd also mention the need for prolonged catheterization in the patient and need for possibility of draining by himself in the future.
Why do you need prolonged catheterization?
During the healing process of a reconstructed urethra.
That is the standard procedure. Yes. How long would you think in your state procedure?
Yes, as a matter of explanation.
No, there are a lot of issues, but then the question is, catheterization normally done for how long? For each stage, let's say. How long? What is prolonged? You're saying prolonged. No, what do you mean by prolonged? Catheterization, yes, it's going to be done. When will it be prolonged?
When
the standard of care, catheterization following urethral reconstruction. It will not be prolonged because it's yours. If you develop a fistula, you developed a fistula. So this is what is the surgical approach to this patient?
Since it is a proximal.
Just outline the steps of surgery. You don't have to give the details. Just outline the steps of surgery.
Yes, sir. Since it is a
I think it's difficult. Radius is now no more with plastic surgeons. Let's
Since it's a proximal hypospadias, there are two options possible. That is, one, either we can do a staged Brachus repair, or the use of the onlay flap, preputial flap reconstruction.
I don't know any of this. You have to educate us. What are your procedures that you will do? Number one, you have to check whether he has Cordy.
Oh, okay, yes, sir. Okay, patient will be assessed for the presence of Cordy by the.
How will you check intraoperatively?
Intraoperatively, we do what is known as the artificial erection test, wherein the patient, the proximal the shaft of the at the base of the penis, this is applied, tourniquet is applied, and using a butterfly clamp, saline is injected into the glands or into the corpora.
So
And
now the question is, there are two options: either the patient has Cordy or does not have Cordy. So now tell us what you're going to do for either of them.
In a patient without Cordy, there is we can proceed.
We can. What will you do? You can do many.
We will be proceeding with the reconstruction of the urethra, the urethral plate, that coverage of the urethral plate. Whereas a patient with Cordy, the Cordy release has to precede the reconstruction, and in that case, we can do a simple Cordy release with the urethral excision and closure with, or grafting can also be done for the raw area created post release of Cordy.
Then
the
if there is Cordy, you will have to do a Cordy. That adds to another stage, right?
Sorry, sir?
That will add to another stage.
Yeah, yes. One more stage added.
One more stage. So that becomes 3 stages. So what will you do if there's no Cordy? What you're going to do?
Then we'll be doing a Brachus procedure, which is a 2-stage.
What is that? What is Brachus procedure?
I'm sorry, sir. I'm not able to recall the steps.
Okay, doesn't matter. I think we'll move on to the next case. Any other questions? Any other questions?
Yes, sir. Time is
From the other faculty?
Something
Yeah,
is.
Just to summarize again, five main
Vinay.
phases of hypospadias repair. So 3 stages of the urethroplasty you said. What are the 5 main phases? One is the meatotomy. Second is the Cordy release and correction. Third is the urethral reconstruction. Fourth is the junctional fistula closure, and fifth is the scrotoplasty. So this is the comprehensive overview you should have. Which flap you would like to use, you can then use as per your judgment and discretion, depending on the type you are faced with. Let's go to the next one.
Dr. Balyar Singh wanted to ask something.
No, I think we'll go to next one. Better.
Okay, next patient.
Rohit.
Can you read the X-ray?
So this is a 3D reconstruction of the facial bones with the mandible, which is showing the first image is the anterior posterior view, which is showing a fracture line which is running at the involving the inferior orbital rim and involving the zygomatico maxillary buttress, and then we can also see the zygomatico-frontal suture, which is fractured and slightly displaced, and so it's a mildly displaced left zygomatic complex fracture. And yeah, zygomatico maxillary buttress. And also there's fracture over the maxillary alveolus, and the fracture line is extending up to the the dental process of the maxillary of the maxilla also.
Maxillary incisors between the second incisors and central incisor.
Between this
central
central and the lateral incisor on the left side of the maxilla.
Yes. Questions? Yeah.
How many fracture lines are there exactly? Okay, you want to fix the, what is your management? Then we can discuss the fracture line. How do you manage?
Initially, the acute phase, we would do the AT, we'll follow the ATLS protocols.
No, let us, it's only 10 minutes. Let us go for the management first.
Yes, ma'am. So now I would like to do the fracture fixation for this patient. So
open reduction internal fixation as a plan of management of a case of mildly displaced zygomatic fracture with fixation of with 3-point fixation. 3-point.
So I would like to get because I'll need IMF. I would ask the anesthetic team to do a nasal intubation for this patient. Following that, I would do the intermaxillary fixation first. Following that, my plan would be to fix the infraorbital rim. Going from top to down approach, I would do the zygomatico-frontal suture fixation first, then the infraorbital rim, and then I would fix the zygomatico maxillary buttress, and and also the IMF will take care of the dental, the alveolar fracture of the maxilla. So 3 fixations.
Why do you want to do IMF for this patient? Is there any occlusal disability? Can't you just?
Because the fracture line is involving the alveolus of the maxilla, ma'am, on the right side.
Yeah, so, but is there any occlusion derangement here?
From the scan, doesn't seem like there's any occlusion.
What is the normal occlusion?
The mesial buccal. The mesial, the mesial cusp of the second molar lies.
Second molar of the maxilla lies over the lingual side, the cusp of the first molar of the mandible.
So by seeing this X-ray, do you feel is there any problem with the occlusion?
Ma'am, it doesn't seem to be any gross malocclusion that can be identified.
So in that case, why do you want to do a intermaxillary fixation for this patient? Can you do something else? And what are all the approaches you will have for this open reduction and internal fixation of the fracture zygoma?
We would prefer an intraoral approach, ma'am, Keen's approach to fix the zygomatico maxillary buttress, and also we would do a subciliary incision to fix the infraorbital rim, and I would also get the extension on the of the lateral eyebrow downwards to expose and fix this zygomatico frontal suture, ma'am.
Okay, with the Keen's approach, you will take care of the zygoma. But for this maxilla, do you want to do a IMF? Somehow I don't want to do IMF for this patient. Anything else?
Placement of
eyelid placement, ma'am, or if not,
how is the fracture line there exactly?
Actually, there is a little this X-ray shows a fracture into the maxilla, which does not follow the classical pattern.
Yeah, it's a transverse fracture. Yeah.
There is a vertically oriented fracture which is going in along the lateral border of the piriform fossa.
Yeah, but
so I don't know if is there a Leafort 1 associated with this or not.
See this.
It's
50% fracture is actually it is there is a fracture going on left segment. There is a Leafort 1 fracture of the maxilla.
That's what it says. 50% Leafort. On one side.
Yes.
Yes, yes.
And there is gross malocclusion actually. Either if you are plating for the zygoma, then that also you can fix the maxilla as well.
Yeah, in
And
the
fix
same
the
approach,
maxillary
actually, you
buttress
can put a common plate to the maxilla and the zygoma, keeping the occlusion intact. That's what you don't need a IMF. Maybe preoperatively, perioperatively, you can do IMF to see the occlusion, to make sure that your occlusion is good. But anyway, you are doing a open reduction through the Keen's approach. So in the same approach, you can put one more plate for the maxilla also. And arch bar. I think an arch bar will do.
If you can't do plating or you don't have a plating system, can you do anything? What is done? Let's say open reduction and internal fixation is the current management of treatment, but let's say you don't have access to plating.
We can.
There's a Leafort 1. Now we've discussed that this possibly is a Leafort 1 with a zygoma. And there is malocclusion.
So we can just reduce the malocclusion and do an interdental wiring. And
How will that work? As soon as the mandible moves, the whole maxilla will move. So that comes to my question: what is the principle of oromandibular fixation in these fractures? When you have a maxillary fracture, all has to be stabilized with the skull, right?
the mobile segment has to align with the.
Yeah. So the mobile segment here is the maxilla. So you have to first reduce the maxilla onto the mandible, and then the whole thing has to be fixed to the skull.
Yes.
Right?
Yes, sir.
So if you do that, how do you fix it to the skull for a maxillary fracture? Basic principle. You know about internal suspension? No. Okay, come on, let's move on.
See, this patient, I don't know whether discussion has been done, because the fracture actually it is going. Did anybody check for the floor of the orbit in this patient? You check for the floor of the orbit, because the way this fracture is, floor of the orbit also may be involved, and also there is this anterior part that is fracture, that probably is a combination around here. Fixing may be a difficult area in the zygomatic-maxillary area on the floor of the orbit. And also, what I would do for this patient is, I'll naturally reduce the maxilla and put everything in occlusion and then start plating. And also, of course, floor of the orbit need to be checked. If there is any teardrop sign or anything is there, in the CT scan, so that also need to be addressed either through a bone graft or whatever implant you like to use. Then fix both the segments. It can be fixed to the opposite side of the maxilla, and also zygomatic maxillary buttress also will stabilize the maxilla. And if you feel that maxilla that needs to malocclusion, then once you have fixed the arch bars, then training elastics can be given to maintain occlusion, because in maxillofacial injuries, maintaining occlusion is the first line. That is the first aim, is to occlude, have a good occlusion. Then fixation part is taken.
Yeah, you should know the principles. We'll move on to the next one. Instrument. Okay.
Sir, with the instrument here is what appears to be an expander device, implantable expander device, with the expander itself and a hub connected to the port. The wire connected to the port, which can be used for the purpose of
You have to identify this product, this item, that is a tissue expander.
implantable tissue
So you
expanders.
implantable tissue expander. So
Yes.
now you have to qualify that specifically. This is with a
with the expand
inflatable port,
balloon with attached to a port for the
this is attached to a port. So
port.
what sort of a port? This. So that comes to my question: what are the types of ports? So this port is a distant port, right?
Yes, sir. Yeah, yes.
So what is the other type? That's my hint.
It is
which is
the local
present
port
within the, we can inject
directly into
with-
the
into the
balloon
expander.
itself. That is the local.
So there are incorporated ports.
Local ports.
So how do you identify those incorporated ports? Probably not commonly used these days. There are a lot of drawbacks of having incorporated ports, but the advantage is you don't need to make a separate
placement
and a separate tube, etc. So I'll just run through it because it's 10 minutes. So how do you identify those incorporated ports?
Do you need another device for it?
An ultrasound device to. Sure, I'm not.
No, there's a magnetic device which you can hold in front, and there's a metal on that port, so it identifies, and then through two cross sections you can. Otherwise, you will puncture the balloon. Questions, please. A lot of questions on the expander.
Where do you try to place this port? That is
sorry, ma'am.
the port. Specifically, where do you place it?
In a subcutaneous pocket, so as to be so that we can infiltrate it with the saline
Away from the
site of the expansion at a subcutaneous site, so as
which
to
is
be
more accessible. For
You still have to qualify. Still more. Yeah, madam.
Subcutaneous means suppose this is a cheek. Can you put the port here?
Away. Yes, no, ma'am. It has to be in a place which is hidden or away from the site of the.
Wherein the port should not move. There has to be it shouldn't be placed in a cavity or a place where wherein the it should be easily accessible and superficial, and yet there should be place for the port to kind of hold and sit in that place.
And where should it sit on?
So that while injecting, it doesn't get displaced. We do not
get displaced. You're going to start injecting. You're putting it into a subcutaneous pocket. No, you're not going to put it into a cavity. You're putting it into a subcutaneous pocket. So, but underlying that, what should be there?
a bony to give counter pressure, there has to be a bony structure.
There has to be something rigid underneath, right?
Yes.
Any other questions? So can you tell us more about this type of expander? There are various shapes here.
Yes, sir.
Okay. Anything else?
So there are also the self-inflating type of expanders, which over time by
in this item.
Yes, sir.
What about the base?
Yes, sir.
You can have a.
So the base can be either flat or that could also be one of the surfaces where the expansion can occur, sir. So
you can have a rigid base or non-rigid base.
Okay.
So a rigid base will not expand. The other areas will expand.
Yes, sir.
So unidirectional expansion. Whereas if you don't have that rigid base, it will expand in all directions.
All directions.
How you determine what volume of the tissue expander is needed, what volume is needed? How do you calculate that I want 750 cc or 600 cc volume expander for this patient? How you determine that? Okay.
Multiple formulas.
Have you seen a case? No.
Yes, ma'am. We have seen
Wow.
two cases where.
So how did you measure that defect and the volume of the expander? You must have seen that.
Yes, ma'am. The base of the expander will be equal to the base of the defect, but the height is the one which determines the volume or basically the projection. I'm not sure how to calculate the volume. It depends upon the size of the expander also. And
see, whenever you are using a expander that has a volume, say 200 cc, 250 cc, or 500 cc, or 700 cc. So we expand to that volume, or you can still expand more.
can go a little beyond also, sir, until the patient can.
How much beyond?
Usually, sir, until the patient can tolerate the pain.
That is from the patient point of view. If you are expanding the expander, how much you can expand the expander?
Up to 5%.
At least 2 to 3 times. Okay.
You have to measure the defect, and also you have to measure the amount of skin available adjacent to the defect. And based on that, you will plan your expander. Yes, exactly. So how much is the width of the defect and the length of the defect, what size and what shape of the expander you can place an order. So for that, you need to measure the defect, and also you need to measure the adjacent skin. So for example, the length of the defect is around 10 centimeters. You can order 10 centimeters width, and also maybe a little less. And the width of defect is some 8 centimeters. So you need 8 centimeters of skin expansion there. So 10 into 8. And with that, the height of the expander, how much is the height of the expander? So you will have that measurements in the tissue expander catalog. So based on that, depending on the skin laxity, you will order. And for example, it's a 300 cc expander. So you will expand 300 cc, and over and above, you can always expand another 100 cc. So 400, 500 cc also, as long as the skin permits, basically. For example, you are happy with your expansion, you can go for your second stage. So always your adjacent skin availability and also the defect size. Based on that, you have to see the catalog of the expanders and you have to order accordingly. You can go to the next.
Okay, next question. What is your diagnosis and management? That's the question.
The diagnosis of this patient would be bilateral lymphedema. From this picture, it's not clear. It's definitely an older individual, so probably secondary lymphedema, and it is more. It is involving the right limb more than the left limb, and the disease is concentrated below the level of the knee. So, and most probable cause would be in an adult would be an infective cause. I would say filarial infection. So I would like to do the relevant investigations in the patient, as in I would get lymphoscintigraphy in the patient to assess for the status of the lymphatics and also do the antigen study for the filarial infection. And I would start the patient immediately on management protocols such as limb elevation, then massaging, graded massaging, and also a compression therapy, the 4-layer bandaging, 4-layer bandaging, and
MLT, the
So it's a bilateral edema lower limb, lymphedema of lower limb, right?
Yes, sir.
So now you're saying it is possibly filarial. So you have to
Yes.
also mention that there is no signs of inflammation or infection here.
Uh-huh.
What is
Yes,
the
sir.
role of long-term antibiotics for these sort of patients?
These patients are due to the accumulation of lymphatic vessels, the dilated lymphatic vessels within the these parts. Patients are prone to get infections from the unhygienic skin creases and recurrent infections.
What sort of which organisms are commonly seen?
Skin commensals.
And gram negative, it could lead to gram negative sepsis, leading to
Gram negative or gram positive?
Gram positive, like the skin.
What is the most common
cells, like
commensal of skin?
staph aureus.
Yeah, staph aureus.
Epidermis.
So that is the most common. So you have to have usually what is given, what antibiotic is used for these sort of patients?
Doxycycline prophylaxis. So doxycycline prophylaxis.
Long-acting penicillin.
Acha, penicillin. No.
Can I have a question?
Yeah.
Yes.
Professor Vishwas, can I have a question, sir?
Oh, Arun Chaudhary.
Oh, sir.
One question,
Well,
please.
nice moderations by our faculties. I just have a single question to these students. What is the Chatterjee's classification of lymphedema, mostly of viral origin, in Indian scenario?
Chatterjee's classification.
Chatterjee, Dr. Chatterjee's classification is a very common. There are multiple classifications abroad, but this condition of filarial is more common in our country. So Chatterjee has classified, and in that classification, the management treatment is also been made out. Any idea about it?
So is it a sir? It's a physiological stage-wise classification of.
Yeah, stage 1, 2, 3, 4.
Stage 1, there is disease process has begun, but there is no obvious edema that can be noted.
There will be edema, but pitting edema, it will go by rest.
Elevation and yes, sir.
Yeah, second stage also same thing. Little more, it goes by less and pressure therapy, intermittent pressure. Because you told about, in this case, this will be stage 4. And
Yes,
if it is lymphedema having lymphidiasis with other complications like ulcers, infections, it will not respond to the compressions. Now there is a surgical method has to be undertaken.
Yes, sir.
So all these diagnosis with the treatment will depend on the stages.
So
Okay,
just outline,
thank you very much.
Outline your management quickly.
So we'll be initiating the patient on continued antibiotic prophylaxis. If in ongoing infection, then antibiotic treatment will be initiated. Patient will be initiated on physiotherapy and the MLT treatment. Multi-layered compression bandaging can be done for this patient, and patient will also be educated regarding the possibility of rapid decompensation upon infection, and to present to the hospital on emergency basis. In this patient, will be counseled accordingly for the management, surgical reduction of the lymphedema mass itself, which can either we can give them the option of undergoing one of the reduction procedures such as Charles's procedure or Thompson's procedure, or we can the debulking procedures, or we can also offer if it is in one of the earlier stages, we can offer.
See, there is bilateral edema.
Yes, sir.
Your management is uniform for both the limbs. Looking at this patient.
No, sir. The more
you're talking about all this the right limb, right?
Yes. The more grossly enlarged limb.
Possibly the left limb may not require
the surgical
procedure.
Yes, sir. We could do
Surgical procedure may be required. That will depend on your lymphoscintigraphy.
Yes, sir. Condition of the lymphatics.
You can also do ICG.
Yes,
yes,
sir.
one of one of the modalities for
ICG.
So which is preferable?
The lymphoscintigraphy will give us an objective, or rather will give us a anatomical.
But ICG is non-invasive, sir, and it is more like.
Non-invasive. You have to inject the dye, no?
Yeah, yes, sir. But
It's not radioisotope,
no
but you have
radiation, no radiation, and
Both are invasive. You have to inject the dye in both. One is radiated, one. In lymphoscintigraphy, it will just give you a pattern of how the lymphatics pass. ICG will give you a pattern. On that basis, you can decide on adjuvant treatment, means what sort of surgery you will do, other than debulking.
Yes.
Whether you would do some sort of a lymphovenous or a lymph node transfer, depending on what your lymphatic patterns are. Questions? You have to know about MLD. You should know how MLD is done, what is the principle of MLD, and compression bandage, multi-layered,
Multi-layered
and usually Charles procedure and all are not done. What did you say?
Liposuction as
liposuction is a better option these days. You might then do a skin excision after further redundant skin.
Suppose you want to do a lymph node transfer, you have seen a good lymphatics there and you want to transfer. So what are the donor sites?
You can use the submental group of lymph nodes can be used.
Yes, ma'am.
We have seen.
Our institution, we have used, so far we've used a submental island and islanded flap to the groin for the relief of lymphedema. Alternately, we can also use an omental flap to for the relief lymphedema.
Is it a pedicelled omentum or free omentum? Is it described for the lower limb pedicelled omentum? Is it described?
Free omental flap is described for the management of lower limb lymphedema.
Free omentum is done, but in the olden days, they used to dissect the whole omentum and tunnel it into the lower limb. So that was also described. Next. Anything else?
Is there any way you can measure the volume of the lymphedema lower limbs?
Sir, there is an impedance, the laser impedance spectrometry or a volume with a what is that? Yeah, there's a volume where the leg itself is placed into a chamber containing liquid. The displacement is used. The displacement volume of displaced fluid is used to identify the excess volume of lymphedema, excess volume of the limb that is there.
So you have linear measurements and volume measurements. So you take circumferences at various levels, marked levels of soft tissue or bony prominences, and then you have linear volume displacement measures, and you have impedance electrical spectrometry methods. So they give you all volumes depending on the resistance to the impedance. So it's called BIS, bioimpedance spectrometry. Okay. So Dr. Biswas was asking about long-term antibiotics. Why do we give long-term antibiotics? What is the reason? Which is this parasite which causes this, and do you know the life cycle?
The Wuchereria bancrofti. And
so what causes this lymphedema in filarial lower limbs?
I'm sorry, sir.
How does this organism cause?
During the part of the life cycle where the microfilaria lodge at the lymph node, lymphatic tissue of the reticuloendothelial and lymphatic tissue of the body, and that leads to chronic inflammation and scarring of the lymphatics, leading to blockage of blockade of a.
Is that the reason, or is there some other reason? So why is there
what acute condition patient will present? Suppose if the patient has an infection, he comes acutely, an active Wuchereria bancrofti infection.
He will come with periodic fevers, the nighttime periodic fevers, or in an I'm like a patient with parasitosis or a patient with lymphedema.
Parasitosis.
A patient with parasitosis will present with the
they'll come with acute lymphangitis most of the time. So to prevent that, we give periodic crystalline penicillin. That was the practice. Even today, it's a practice.
Madam, time.
Yeah, let us go to the next.
So this is the condition is a post-burn contracture of the right hand involving the dorsum of the distal and involving the distal aspect of the forearm, both volar and dorsal, and extending on to the dorsal aspect of the MCPJ of the index to little finger, and
There are specific questions actually. So you have to just answer that question.
Yeah.
What is this condition? What are the causes for this condition? So what is this condition exactly? You have mentioned it's a post-burn contracture.
Post-burn contracture of right hand involving the
all five fingers
all
of the
five
thumb.
fingers.
Involving the
All digits, with
the wrist and all the digits, ma'am.
No, there is a specific deformity which we are worried actually.
With the clawing of the
is that one
with flexion deformity of fingers. So it's a grade 4 post-burn contraction.
It's a metacarpal joint.
MP joints.
MP joint hyperextension. So if the patient has a MP joint hyperextension, the hand is useless. So that's why we are worried about that thing. So specifically, it's a post-burn contracture of the hand with MP hyperextension and flexion of the eyepiece. So that's what you have to tell, because the wrist is it's almost in neutral position. Maybe little flexion is there, so you are not really worried about the wrist. What is functional position of the hand?
Functional position of the hand. The wrist is at around 20-degree extension, and the MCPJ is at 90-degree flexion, and the IP, the interphalangeal joints are in extension.
And
thumb?
And
you don't talk about the thumb.
Yeah, that's what.
The thumb is abducted and flexed, abducted and flexed and rotated. There is internal rotation of the thumb.
So here everything is opposite, no? The thumb is adducted, there is a MP hyperextension and the PIP is in flexion and wrist is slightly in flexion. Okay, what are the causes for this condition and how will you prevent it?
In this patient, it could have been due to second-degree deep burns involving the right upper limb, and
failure to initiate early physiotherapy.
How will you prevent?
Keeping the as soon as the patient was received and the initial management was done, the patient hand is to be put in a intrinsic plus position, splintered in an intrinsic plus position, and
early onset of physiotherapy, and
physiotherapy in an acute stage is a difficult proposition in an acute burn.
Splintage of the hand in the intrinsic.
You need to splint the hand. So
Yes.
what is the position of immobilization?
The hand is to be splintered in the intrinsic plus position, wherein the there is no intrinsic plus position. Yes, sir. The hand is to be splintered in the intrinsic after dress. Upon the dressing, the hand is to be splintered in an intrinsic plus position, wherein
What
the
Is that position go? Does that position go by any name?
Tell us the position.
Just now I mentioned, right?
functional position of the hand. Right?
No,
The hand
don't give names. You
Go by
tell us what is
anybody.
the position.
Can you show us the position?
yeah the
90-degree flexion at the MCPJ, extension at the IP joints, and slight extension at the wrist joint.
Does this position go by anybody's name? Like something called the safe position of someone? Safe position of James. Okay, that's not important, but yes. But why is it important to have this position? Madam mentioned there was this hand is useless because of some reason. There is a deformity at the metacarpophalangeal joint. What causes this deformity in burns? What is the reason and why do we have to give early position and splintage in the right position?
Yes.
The scar
Secondary
was
scar contraction that happens.
What are the basic functions of the hand?
Grip, as in to hold the substances, like in a cylindrical grip, round
So
grip.
what is it called? You just mentioned.
Pinch.
There is pinch and
Pinch and
Pinch,
grip.
chuck and pinch, grasp and chuck.
Grasp, sorry. Pinch
okay,
and
pinch and grasp.
grasp.
Then there are various types of pinches, right?
Yes.
So when the hand is like this, he won't be able to hold any objects. That's why that hand is useless. So it's the glaring thing here is the MP hyperextension. So that has to be corrected.
Is there any ligament issue in this situation, in this position?
What happens if you don't do a proper splintage in the acute condition? That's relevant to that question. That's why I asked. What happens exactly? Why it goes like that? Why it goes into that function?
It leads to shortening of the extensor apparatus. And also stiffness. There's also stiffness of the joints and the collateral ligaments, which can result in this.
What do you mean by collateral ligaments? What happens to the collateral ligaments?
The collateral ligaments become shortened because of the contracture. Okay, they become shortened. They become displaced more volarly.
So to prevent a collateral ligament shortening, what do you do?
So we have to splint it in to keep
fine.
it stretched. We have to splint in this position.
So that position, how does that collateral ligament is not short in flexion, but is shortened if it is in a neutral position or in extension? What is the reason?
Something specific about the joint.
So because it's the way in which the collateral ligaments run, sir, as in they cause flexion at the MCPJ and extension at this joint, at the interphalangeal joints.
Collateral ligaments don't cause the
Sorry,
collateral
sir.
ligaments
Here.
are not an active motor function.
Yes, sir. Actual function is at the
stable.
MCPJ. Yes, sir.
So what happens? What is there in the collateral ligaments that remains tight on keeping it at 90 degrees flexion, but in hyperextension it's short?
To maintain their length.
Because of the joint.
To maintain the length of the collateral ligaments, you have to keep them in flexion, because when they go into hyperextension, the ligaments, they get shortened. So you have to maintain the length of the ligaments. So that's the reason you are keeping them taut by keeping the MP joints in extension flexion.
So if you have a wheel, with a central axle, it's a central axis on which the wheel rotates. So what is this joint? Classically the MCP joint is described as a sum joint, a 3-alphabet word. Any idea?
What is this joint? It acts as a hinge joint, sir, around which.
So it's a cam joint.
Yeah.
A cam joint is an eccentrically placed joint in which the fulcrum, the axle of the wheel is eccentric, not at the center. So that is why the movement of the MCP joint finger is across a eccentric axis, and you get long length in one aspect and shortening in the other aspect of the collateral ligament.
Sorry.
So that's why it's important. Most important thing in burns is to keep the hand at the 90-degree position in which the collateral ligament is kept
extended.
Extended.
Let's move on to the next question. I think, what is your stepwise operative management plan? Just instead of we'll skip the meal. In this, what is your stepwise operative management plan?
Sir, in this, we will have to, the scar does not look good. So we will have to, it's a hypertrophic scar. So we'll have to do scar excision would be a better option in this patient. So we would like to do contracture release along with the scar excision and straightening of the digits, fixation with K wire to maintain the position, and preferably cover the defect, which will inevitably have exposed tendons with a flap cover. So that would be an ideal plan.
So you want to put a flap cover, which will be a bulky flap, but you need, what is your objective plan and management in this patient?
So to provide
To reverse
management of the scar.
no, sir, to provide the function at the level of the wrist so as to
As we were discussing, would be what is your objective?
So MCPJ will have to correct
Yes.
the extension.
Correct the MCPJ. Now tell me how you're going to correct the MCPJ.
Release of the collateral, the release of the collateral ligaments.
Release of the collateral. You divide the collateral ligament. What happens for a long-standing dorsal contracture? What would have happened to this joint?
So joint would have undergone stiffness or reduced joint space.
What becomes stiff? Because of shortening of the?
The collateral ligament, there is shortening.
Capsule of the
Capsule,
joint.
yes. So we have to do capsulotomy to make this
So
joint.
you may have to do capsulotomy. So you will release this joint. So
Yes.
you're going to put a flap now across that capsule. The question is, what is your stepwise? If you addressing the scar with a flap, okay, I can still understand. But our aim is to get the fingers into flexion at 90 degrees.
Yes, sir.
You have released the joint, you've done a capsulotomy.
Yes, sir.
So then you will need a flap, which is going to cross and go into your PIP joint. I mean, sorry, your proximal phalanx.
Yes, sir.
Because you have to cover that joint, no?
Yes, sir.
So, but that is not ideal. Putting a flap on the finger is not ideal. And it will be difficult to put it on 4 fingers. So that's why the question, what is your stepwise operating? So number 1, you will use tourniquet.
Yes, sir.
You'll use tourniquet. So you should say all that, no?
Okay.
You use tourniquet. You plan to excise the dorsal scar, and your incision has to be designed much more proximally, and then you allow that skin flap to go back distally. So I can't show it here, but let's say if you do in the middle of the metacarpal and elevate that skin flap, then the grafted area, that skin slides distally. And
so
you
it opens up.
cover your capsulotomy. Then
Yes.
you can do your flap for the first web space as well as your dorsum if you want to, or you can also put a graft if tendons are not exposed.
Yes, sir.
So I think we'll move on to the next. We are getting short on time.
Yeah, they're already changing it.
Isn't it? So let's just, how many, what is left?
Yeah, this is the last one, I believe.
This is the last. Okay, fine. Perfect. Come on. How will you document all aspects related to this condition?
So I would first document the history, sir. History with which the parent brings the child to the OPD. Then I would ask you whether this is the lesion is present since birth, or whether it was acquired at a later date, and any increase in the size or increase in the size of the lesion as the child grows, or for that matter, even any decrease or a reduction in the size of the lesion, that will also be documented. And then I would also document in this patient, the interpalpebral distance seems to be less on the affected side, that is the right side. So I would document this finding as well, because it is involving the whole of the upper eyelid. And I'll ask if there are any other lesions, any other similar lesions in the elsewhere in the body. Then I would also do a proper a CNS examination of the child as well, because there might be associated cranial associated syndromes or cranial extension of the hemangioma. So I would also get a neurological pediatric neurology assessment by the neurology team, and to rule out any syndromes. And yeah, and for during their serial visits, we will keep mentioning the size of the lesion, whether it is increasing or decreasing, to keep a track of the variation. And vision is also important. In this case, might not be affected, but still we would want to document the vision of the child. And then if the child has already been treated before for this condition, or any medications, if the child is using any topical medication has been used, I would document that also.
Did you mention anatomical distribution of the lesion? You have to first document the extent of the anatomical distribution.
Yes, sir. The area of involvement, the extent of the lesion, the structures that it is involving. And there are two other lesions on top which look like satellite lesion. Matlab, as in, it's not a part of the lesion, which is the bigger lesion. So I will mention that also. Then
You have to have a documentation and measurements, okay?
yes, sir, measurements and extension.
So we are talking about, I think, subsequently also you'll have to do that.
Yes, sir. Serial visits, we will keep mentioning the size, variation of the size of the lesions.
So what syndromes are associated with this sort of lesions?
So we would diagnose this as a case of capillary hemangioma, and capillary hemangiomas can be associated with large intra hemangioma, this DIC syndrome of DIC associated with Kasabach-Merritt syndrome.
Kasabach-Merritt syndrome.
It can also be associated with which is Kasabach-Merritt syndrome is described as a intravascular hemolysis leading to DIC in a patient, and in a large capillary hemangiomas, and case of Faces syndrome, where there is multiple that acronym PHACES syndrome, wherein there is multiple capillary hemangiomas distributed over the head, face, neck, etc.
They might be associated cerebral intracranial hemangiomas
and aneurysms.
Hemangiomas. They could be associated.
This comes under what? This comes under which group of sort of disease? So how are they different from vascular malformations?
So
how are hemangiomas, or are they the same? Hemangiomas, are these vascular?
They're tumors, sir, which is basically increased proliferation of the endothelial cells, which will result in the lesion. This is a capillary hemangioma.
Under
is the normal cycle in these patients, in these disease lesions? Normally, what happens?
How do you counsel the patient?
They tend to be associated with very slow growth, but they will not regress by themselves. They might persist into adulthood.
Usually they regress with age.
So this capillary hemangioma will regress. Normally it will regress.
Yes, it regresses. If it does not, then if there is a residual lesion, then we'll have to do an intervention, either probably.
No, that is later on. So usually these lesions regress. So they are what? Pathologically, what are they? That's why I'm asking you, are they vascular malformations? So you said they are tumors, okay? What sort
They-
of tumors?
They are classified as benign vascular neoplasms under ISS. VSWA classification.
Hmm. So that is because their endothelial cells regress.
Yes,
The
sir.
rudimentary vessels which have been entrapped and not regress, which normally it regresses. You know how the blood vessels form.
Yes, sir.
So they usually regress, but in this patient, it has not regressed. So you at what till usually it starts regressing when? What is the life cycle?
So usually they start regressing after the age of 1 year, sir, by maximum 2 years, or in 70%, I think up to 5 years to 7 years, the lesions usually completely resolve, sir. Around up to 75% of patients, they resolve, sir. Up to 5 to 7 years, we can wait, sir.
Usually it can be growing and regresses after 4 years. It carries on 4 to 5 years, then they start regressing and then may totally disappear, leaving behind a scar. However, they may remain, part of it might remain. But what is relevant for this patient? So what Dr. Vinay asked you, how will you counsel the parents?
So in this patient, as a child, we'll tell the parents that the patient will be kept in observation with serial monitoring of the size of the lesion to have an objective assessment of the decrease in the size. And we'll also be getting
that is what you're going to do. How will you counsel?
So we will say that
Patient is worried, mother is worried.
So we will explain how the nature of the disease and tell that in majority of the cases it will resolve after up to 5 years of age. We'll ask her to wait until 5 years, and if it resolves completely, it can leave a scar, and scar in this area might be conspicuous and also might I don't know.
No, not we'll forget about scars.
Okay.
In any situation, you will intervene.
Yes, sir. If there is bleeding or a sudden, there won't be. Okay, if there's increase in size or bleeding, then we will have to intervene.
Any capillary hemangioma does not resolve by itself by the fixed age of 5 years. Will have to be treated.
More than that, more important than that.
The syndrome.
The development of the. I'm sorry, sir.
Look at this patient. You said it in your.
Yes, a vision. If it is hampering the vision of the child.
Yes. That is the reason you will intervene, even though it is regressing, let's say.
Yes, sir.
So around all orifices, wherever there is a functional impairment, whether it is bleeding on touch, spontaneous bleeding, or loss of local action or to that area, you must address it. So what are the ways of addressing it? Is there any investigation would you want to do, or would you want to go ahead with treatment?
So investigation would be to rule out any other syndromic associations, sir. But to diagnose this condition as such, no investigations would be required, sir. And our treatment options.
So what are the you are most concerned about?
So we couldn't hear, sir.
For this
What conditions, if there is a would you be?
Sir, the voice is.
So we couldn't hear, sir.
No, your question is cut.
What do you want to do for this patient? How do you treat?
Okay, ma'am. We can start with topical beta blocker, timolol. Topical timolol, ma'am, beta blocker, which can be applied to help reduce the size of the lesion. There's also described some use of
Any other basic treatment before that?
No, for this
Any other
patient.
basic treatment.
As in, okay, first is the moisturization, keeping the skin moist so that it does not bleed, and taking care of the lesion so that there is no development of ulceration or bleeding from the wound. So that would be our first priority. Emollients, moisturization of the skin. Then
This patient's already there is a problem. The eyes, you can see the size of the eyes on both sides.
yes,
Here it's almost the palpebral fissure is small.
Yes, those.
He will develop amblyopia if you leave the child like that. So I would like to intervene and give systemic propranolol. I don't wait for the topical propranolol, right? For that you need to investigate what else? Propranolol you want to give?
Yes,
That's the question. What do you investigate?
Read this one. There will be associated cardiac anomalies in the patient, and we should rule out if there are any septal defects in the child before starting propranolol.
Baseline ECG with electrode.
Something else, sir?
I think
Yeah.
you can carry on. We've crossed over time, no?
Yes, sir. Yes, sir. We have almost reached the end of the session.
Okay.
I think Lakshmi ma'am.
I just want to tell one point about your oral cancer planning. That's I would like to go ahead with a soft tissue management with a single ALT flap. That's my plan. Because that will take care of the inner defect and also the outer defect and the upper lip and lower lip. Patient will go for radiotherapy because patient needs a radiotherapy. So we have to complete all modes of treatment as early as possible. So that's one thing. The other point I would like to tell you is that your PMMC flap, which is marked, it's quite high. So the length of the pedicle, it's very short. It won't reach your oral cavity. So you have to, again, learn that properly. Right. What is your plan, Dr. Gautam Biswas, for that?
Our plan usually, these are common sort of lesions that we see. We usually do a double free flap.
Double free flap is, yes, that's wherever you can do in a cancer center.
Standard of care, yeah.
Yes, that is ideal. Double free flap is ideal. But the second option is.
Could you just repeat the question? I lost you all in between.
This patient, no, she was asking me what I would do for the patient, the oral cancer patients. So few points regarding that patient. Number one is that you have to be sure about your excision at your level. And what we practice is, because this patient is definitely going to receive radiotherapy, a coronadectomy is done along with our mandibular resection. So the condyle and a part of the ramus is retained, but the resection is from the temporalis down. That prevents the trismus postoperative post-radiotherapy. So this patient's resection is going to be just crossing the midline. So obviously, I would like to put in a bone. Though the mouth opening is about 2 centimeters, which is not bad, I presume that after the resection, it will become better. But we need to take a point on that. If the mouth opening is very restricted, then you'll have to consider doing just a soft tissue free flap, which will have a lot of disadvantage of malocclusion on the other side. So in this sort of a patient, we would do a free fibula. Because the skin island is big, we would do a 2 free flap. Otherwise, we usually use the proximal perforator in the peroneal vessels as a second island to cover the outer surface, and we do fibula with double island. So that's our usual plan.
Yeah, the ideal is 2 free flaps, but in a average scenario, yes, a soft tissue reconstruction alone will take care of this patient. Most of the time, that's what we do.
Madam, one more thing is, if it crosses midline, definitely.
Yeah, yes.
We do a mandible reconstruction at any cost.
Correct.
And second thing is, if I have to do only, this patient, if it is a hemimandible, I will only reconstruct with anterolateral thigh flap, folded anterolateral thigh flap that I will use. And second thing is occlusion, maybe a issue as, opposite jaw will be pushed inside and downwards. So for those patients, we always advise for bite guide prosthesis to be used for the first 2 or 3 months. So that will usually we'll correct the occlusion and will allow. Mandible reconstruction for this type of patients may not be more advantageous because they will be able to eat the same diet as you have done a mandible reconstruction in this patient. Because for all these patients, they are going to depend on soft diet or maybe semi-solid, maybe towards liquid form because of their overall condition following radiotherapy, other issues. So I'll go only for anterolateral thigh flap. And second thing is, if at all you have to do a mandible reconstruction for a patient who will require postoperative radiotherapy, I'll try to keep the bone segment as long as possible because contouring will, many times we do smaller segment for get contouring, but I will avoid that because the smaller the segment, more chance of osteoradionecrosis for these patients. And I think these are for that patient I have to say. And one more thing, all these patients, they have to be informed, because see, all these patients, even if you have maintained the competency of the lip, still they will be drooling. Drooling is because of reduced sensation. One patient, many patients, and they have to be deliberately told to keep a handkerchief or something to wipe every 5 to 10 minutes. Otherwise, saliva drools because of lack of sensation till the sensation comes back. So these are the few things. And all these patients in head and neck reconstruction, my strategy is very simple. I have to keep the mouth open. I don't have to compromise airways, whatever reconstruction we do. And definitely I'll augment the cancer treatment if it is to be, all these patients require radiotherapy, chemotherapy in the postoperative period. So I'll try to do a flap which will have early primary healing in head and neck reconstruction, especially for cancer. And one more thing, if I can do a reconstruction without dividing the skin paddle, I'll do that. Unless until it is required, I won't divide because I like to keep it as such because dividing sometimes may have other issues also.
One point I think the candidates did not discuss is because this patient is going to lose part of the upper lip commissure and the lower lip, lip competence is important. If you put a flap there and don't do anything, so a sling, I would definitely put a sling between the soft tissue and suspend it above so that the commissure is supported so that this drooling is reduced. That needs to be part of the plan.
Yes.
Dr. Vinay.
I agree with what Amresh has said, so I don't want to. You need a single robust early reconstruction and early adjuvant therapy. So yes, all the ancillary functional training can be done with speech and swallowing therapy subsequently, and a good chin support with a vertical pressure garment. That'll alleviate the drooling. Also, the lower lip, when we are not going to jaw suture the edge to edge of the orbicularis to orbicularis, we will not be suturing, but to the edge of the deepithelialized edge of the folded anterolateral thigh flap. So that is what it is going to resist against and contract. So this lower lip should be given a inset a little higher than the level of the lower incisor teeth margin, so that there's more the sandbagging or a dam effect, so it keeps the fluid saliva within the sulcus of the remaining GB sulcus which is there.
Madam.
Sir, actually the discussion is so extensive and touched each and every important point of each session. What need to be discussed is covered very well. I request the panelists one by one tell the analysis of the page's performance and your opinion about Plastiquest. I request Dr. Gautam Viswasu.
I think they planned quite well. There were certain areas that it was deficient, especially when you're planning, you'll have to have, I think we didn't get time to go into the intricacies of the flap planning, which is going to be a part and parcel of the exam, which is important. But that is why you need to be firm with your plan. If you've made a plan, if you've made a plan and that does not face the questions properly, then there's going to be an alternative plan which may be permitted, but the examiners will have a negative view if your primary plan does not fit. So you have to be absolutely correct in what you're going to plan and do. So that is one. Number two, regarding the short cases also, there were some deficits, especially, let's say, the hand. You should know clearly what is the deformity is, what it causes, why it is caused, and what would be your line of management when these sort of patients should be. And these are standard. I think these are standard questions, nothing very... So otherwise, both of them have done well. They presented clearly and they were explicit. I think that's it. They are on second year. I think within the next few months, they should improve and become much better. Thank you.
Actually, we have to congratulate for both of them coming forward to appear in this competition, though they are in second year. Few people they withdrawn just because they were in second year. Really, I appreciate because they're too.
Congratulations to them to being facing the
Thank you,
exam before.
Thank you, sir.
I invite Dr. Manikumari, madam.
Yeah, they have done very well. Both of them, they have done very well. Because now I'm saying, because I came to know that they're second years.
Yes.
Definitely, they have done well. For because they have one more year to prepare for themselves, and their presentation is good. Yes, the deficits are flap planning, and yes, hand. I think they have to improve themselves some more. And the rest of the things, okay, they have answered okay. That's fine. Yeah. One more year you have. Congratulations. And about Plastiquest, also you want some input, right? So it's giving really good training for all the postgraduates, especially for postgraduates who are willing to come and present in this forum. They will face they have to face people, I mean, seniors across the country, and they will know various inputs from everyone. So it's definitely a good platform, and yes, it's going well. Congratulations to you also.
Yeah, absolutely.
Thank you, ma'am. Actually, they are putting a lot of effort to face the legends and stalwarts of the faculty. But definitely the nervousness will be there. So few points they are lacking. So definitely their performance is improving session to session, ma'am. They are very nice. Thank you very much. I invite Dr. Amresh Balya Singh sir to put your remarks and opinion.
It is very nice to see my younger picture. And I agree with Dr. Biswas and Dr. Manikumari, madam. Actually, both are good. And second thing is, only thing I suggest is, see, whenever we present, try to understand, is the case presentation is not to pass the examination. It is to prepare the patient for operation, and evaluation is the most important part. Whatever you may do, whatever you may plan, but I think we should not miss any findings and examine the patient fully, what the problem he has. And if you think, and second thing is, whatever case it is, And we should understand what is the broad principle of managing that situation. That should be, no, all planning should be done keeping that in focus. And one thing is about the performing in the examination. Only thing I can suggest is to prepare whatever case is there, prepare what questions can be asked from different aspects, and then get ready with the answer. I think this is one of the very easy way one can prepare. By thinking of questions, one definitely is doing an introspection, and also that will improve their understanding. And I feel that everybody put very comments and inputs that probably was very good, and even many things I also learned. And about the PGs, I think they have to read. Second year means after 6 months, they should be as good as their third years. And we always give their first year, second year, no. Once they're prepared, means they should be knowing much more than the others, those who are listening. So they have to prepare very, very hard. And they have to put that effort. And naturally about Plastiquest, naturally it is a good forum. And I think it gives a good exposure to postgraduate students. And they also feel that what is expected of them. And at the same time, it gives also input from the many experienced surgeons, so that what can be done and what should be done, what should not be done, that also is learned in this forum. And I congratulate you and also Plastiquest for this. Thank you, ma'am. Thank you.